Welcome to our Integrated Care Board Part 1 meeting. So welcome everyone. As we get towards Christmas, I'm sure you're as excited as I am about all that festivity coming. I'm sure we enjoy the day as well. We have a couple of apologies. I'm aware of Mario and Rachel Wigglesworth. Poor old Rachel, I don't know why Mario can, but Rachel's got COVID, I understand.
Oh, bless her.
So, dearie me. Any other apologies that I've not spotted, Trudy? No? Okay, thank you very much. And we have a few colleagues joining us over Teams, which is great. I am aware that Al may dip in and dip out as the day goes on, some operational issues, which thank you for alerting to me that Al and Steve as well. You're stepping out a couple of times during the day. So if you see colleagues disappear for a bit, it's nothing else other than a planned agenda. Okay? Right. Declarations of interest. Anything to raise or question on that? Or anyone would like to raise any declarations of interest? No?
John, sorry, I'm trying to put my hand up. It's Ali.
We don't have any questions from the members of the public. Correct?
John, sorry, I don't know if you could hear me. I struggled to
let's
put my
move
hand
into
up, but I wanted to declare a conflict of interest, please.
Ali?
Can you hear me?
Yes.
I can.
Brilliant. John, sorry, I was trying to put my hand up to declare a conflict of interest. I want to declare a potential conflict of interest in the 256 paper, please.
Okay. Thank you very much.
Thank you.
John, can I put a question that was put to me for the board, which is concerns over the planning for the refugees that we have in the county, and I know it crosses all boundaries, council and health, but one of the two specific questions. One, are we planning for what's going to happen when this Ukrainian refugee money support goes away? And two, are we planning for the difficulties that as the increasing number of refugees come in? That's one question. And second is more of a suggestion that given the number of refugees that we do have in the county, would it be sensible for us to have a language line subscription for all services, VCE as well as health and council? If we had one subscription with many users, we could probably have better access than each of our individuals trying to have, because they're quite expensive. And some of the third sector organizations really can't afford it. Okay. So I don't know. I didn't know where to bring it up. So.
Right, no, happy with that at the start. I'll pick it up. I've got a note of that. We'll definitely pick that up as we go through.
Thank you, John.
Okay. Thank you. Anything else that is not on the agenda anyone would like to raise now? No? Good. Okay, so let's crack on. So let's move to the minutes. As usual, I'm not going to page turn. I'm just going to reach out to you all and ask, are there any changes for accuracy that you want, or are you happy for me to sign those off?
John, it's Ali.
Yes, Ali.
Apologies, I wasn't at the meeting, and I don't know whether this is a matter arising or an accuracy, but there was on page 9, I think there is a action. It was on page 9 on my bundle. Let me see if I can find it. There was an action around responding to a question that Steve Williamson had raised around the budget setting in the council. I wasn't clear from the notes what the question was, so I just wasn't sure if that was an accuracy or a matter of arising. But if Steve could maybe email me separately to make me aware of the question, I'll try and get the answer today. Thank you.
Are the minutes accurate?
She wasn't there, so she won't know.
Oh, I see. I'm sorry.
There.
Oh, okay, sorry. So, Steve, can I just look as it's aiming towards you? Are you happy that the minute is what we said we would do, and then you can clarify it afterwards?
Yeah, I think that's correct, and happy to do
Follow it
that.
up afterwards.
It's also referred to, I think, in the NHS partner member provider report and in the next the private part of the meeting.
Okay, thank you. Okay, so I'm going to take that as a set of approved minutes.
Sorry, John. Apologies. It's Emma.
Yes.
I think there was a query. I'm struggling to get my notes up at the moment. There's some IT stuff going on here, but I think last time I raised the point around the previous minutes showing that the LMC was a member of the group, and we should be in attendance. I think that the minutes have got the amendment the wrong way round again. Still, it's recorded topsy-turvily, so we should be not a participant. We should be in attendance, and I just wanted to clarify that, so it's still not quite right.
Okay, I've got you down as an attendee, to be fair.
Yeah.
You have, but I think it was the amendment that I asked for an amendment last time, and the amendment still is showing it the wrong way round. I think if you look at the amendments at the top of the first set of minutes, it still says it topsy-turvy.
Tell you what, I think we'll take your observation. Trudy, could you check it out afterwards? That's a fair challenge. I'm looking at a set of minutes that do say Emma is an attendee, so if you could pick up the point afterwards, but we get your point, Emma, and we'll clarify our understanding. Okay, so minutes approved. Let's move on to matters arising. So Trudy, as always, if you could just point us in the direction of the ones that you think we have outstanding.
They are all kind of picked up, and they'll be picked up.
Very good. Thank you. People happy with that? Yep. Okay. For colleagues on the screen, it is difficult to see the virtual hands up. So if you want to wave, I might be able to see that. So apologies for that. Okay, so we'll go on. So on the chair's report, the only thing I would like to draw to your attention there, because again, like a lot of these things, I want you to take these things as read, is Mario sent across a report that Healthwatch had done on suicide. The attachment to that is on the link on the agenda. If you still were struggling to find that, somebody asked me how they got to it, so it's on the link. But I think it's a really important set of insights and comes on the back of our suicide prevention strategy that we had actually a couple of months ago. Debbie, is that fair?
I think it is absolutely insightful, and it's our intention to invite Mario and colleagues to the CFT board as well, so that we can actually further talk through some of those findings. There were some positives to take out of it as well, but I think there's also some direction in there about our potential for greater integrated delivery, both between secondary care, mental health services, primary care and the VCSE. I think there are some strong hints in that, and I think it would be really helpful if we can pick that up as part of our future planning.
Very good. Yes, no.
Chair, one question that came up through me sending this report to someone within our organisation is I'm never very clear when reports like this come out whether there's an expectation on us to read them and make sure they get to people for whom lessons might be enacted, or whether they go to everyone who could enact such lessons. I'm never very clear of the breadth of distribution of such a report, and I just want, it worries me.
So I'm going to turn now to our partner representative for mental health and this type of thing. So, Debbie.
So I welcome the question. I think this is just the sort of thing, but we need to test it with colleagues, that we are setting up. So we have a system SRO for mental health, learning disabilities and autism. If we had a fully functioning multi-professional, multi-agency system board, this would be the sort of thing that would be noted under their business to ensure that their transformation plans reflected some of the recommendations. Now, some of it is, there are very clear messages for providers, currently BAU services, but there's also some strategic responses to it. So I wonder whether, and I know we've got a conversation about what does the group reporting into TC4C do? Is it only transformation, or is it going to hold a more general ring on this portfolio? So I think we need to pick it up.
Okay, Mary?
Thank you very much, John. I really welcome this report. I agree, Debbie. I think there's some real positives in it, as well as some things that are of concern. I think my point you may have just covered, but my question I did write back to Mario was, how are we mapping across the findings of this report with what we're actually doing operationally, and how are the two going to inform each other? Because I wasn't sure where to find that information.
Okay.
I think when we come on to the item on the agenda around the integrated care partnership strategy, Mary, there is something that Ali and I are talking about how we map the outcome frameworks for adult social care, for the NHS, for children's services, and what sits in the Health and Wellbeing Board, so we can be clear where actions sit, so we can have an overarching paper, and then we know which groups we're asking to address which actions, and we can bring it back in an organised way. So Ali and I will pick that up as part of the work around the functions mapping, and Rachel O'Connor and Rachel Rotherow have already started that piece of work.
Okay, thank you.
That's great. Thanks, Kate.
Thank you. Just to draw to people's attention, when my report was transposed into the template, I can see that the dates have slipped across in terms of our performance in terms of ambulance delays. So apologies for that, but hopefully you can work out the dates and the numbers. The one thing is that things were getting so much better. I think it's probably helpful, Steve, if you give us a little update in more detail later on, because this was written at a point in time and there is more information. Are you happy to give us
Yeah,
more?
very happy to do that, John.
Thank you very much. So the only thing I want to tease out from the report is my second paragraph, which is really about a one system view for us looking forward into the future. It's very timely for us to focus on the immediacies of things, but we can't trade off today's issues for tomorrow's, because tomorrow's will become today's. So I just want to make everyone aware that we're going to be going through the winter, and that is our focus. But as we go through the winter, we need to start thinking about 23-24 and the implications of that. So as we get into things like delivery plans, as we start getting into budgeting, financial planning and that kind of thing, I think we just need to start, as the board meetings session 1 and session 2 take place, is to challenge ourselves about agreeing timelines so that we can collectively do things as one group. That's going to be the challenge, because we're going to be collectively challenged to deliver better and faster and within budget. Any other points on my report? No? Lovely. Okay, thank you. So we'll move on to the Chief Exec's report.
Thank you. Most of the report can be taken as read. There's a couple of things I'd like to focus in on, and then there are some things that have happened since the report was written. I attended an Eden business breakfast with Emma Rouse, and I have to say, for those of you who haven't been to an Eden business breakfast, they're really good places to make cross-sector, cross-agency contacts that you would never make in your normal working life. And the surprising thing for me was we've got an awful lot of commonality around the issues that we face, but also the end-to-end explanation to our public around why things are the way they are. So there was Jill from South West Water was there talking about how we're going to re-wet Cornwall, looking at some issues around desalination, but we don't link that with the £30 off your bill if we can reduce our consumption by 30%, with the fact that we're almost still in a drought, given that it's been raining very heavily for a long period of time. So there is something about how we do the end-to-end, reaching across our corporate services, so our public understands some of the issues that we've got. One of the other things that was really helpful was Matthew from Pride Cornwall was talking around a challenge that they'd had around broadening their constituency. And they are going to start talking around no haters in Cornwall, which I actually quite like as a very simple message around everybody matters. So Emma and I are talking about how our ED&I strategy, we could maybe reframe the language that people use and start talking about no haters in Cornwall, and that nobody should tolerate feeling uncomfortable, whether it's physical, psychological or emotional bullying or intimidation. And then we started thinking about how we might get some of our younger people to potentially narrate our strategies so that they're written in the language that people understand, and maybe then we use infographics. So for people who don't like the written word, there are ways in which we can communicate. So we are going to start picking that up, and for our engagement strategy, our ED&I strategy and climate resilience, we'll be talking to a whole broad range of people across Cornwall around how we land that well, and then how we use those to influence the way that we work. So I thought it was really exciting, and thank you, Emma, for your help and support in that. I've also, not in the report, Patricia Hewitt started her review into how ICBs can be made on a firmer footing and to be consolidated well into the architecture of public sector delivery across the country. She was really clear there's no intention to reorganise ICBs or to force any changes in them unless local collectives think that they should be working in a different way. I know she's engaged with our NHS providers and with the ICB chief execs, and she's got a broad engagement planned over the next few weeks. Her terms of reference are very short and very clear, and maybe we could put a link with them, Trudy, onto our website as part of our public understanding the work that's taking place. So I'm looking forward to engaging with that going forward. And my last piece of update was around clinical leadership that Steve and I are jointly attending on the 14th of December. Debbie unfortunately can't be with us because she's clinically engaging in a different fashion that afternoon. But we're trying to bring together a broad group of clinicians across our county because we know the next 16 weeks are going to be very challenging for our most vulnerable. We know that we've got high levels of vacancies in our busiest places, our wards and points of delivery, both inpatient and outpatient across the county. But we equally know that we've had a growing number of appointments in other parts of our system. So we need to start talking about discretionary effort and voluntary redeployment. We aren't in the level 4 national emergency whereby we can ask people to redeploy. We need to ask people for their views around what we could do to make services safer. So I'm really looking forward to that. And just as we did with COVID, we need to put our clinicians who know what they're doing at the forefront of making decisions over the next 16 weeks. And I would love them to give us a collective headache around how we manage business as usual from non-frontline services while we free up everybody else to make the county safe. And then that's my report, John. Thank you.
Thank you. Any questions? So I just want to tease out a couple of points, Kate, if I may. In terms of the clinical prioritisation group, you say it's going to be established in January. With our, hopefully, appointment of our new Chief Medical Officer, are we able to sort of...
We're allowed to say who it is.
Would you like to share?
So, so this is Helen's last board that we need to thank Helen for her time and effort with us, because although she's been with us for a short period of time, she has challenged us to think about things in a different way, and part of her legacy will be the clinical prioritisation group and making sure that that's up and running properly. We've appointed Chris Reid for a fixed-term contract of 12 months. So Chris came back to us from New Zealand. It seems to be our preferred recruitment route. And he's currently working part-time in West Cornwall Hospital and part-time for CFT as an acute GP. Oh, no, he isn't. He's part-time West Cornwall Hospital and part-time in Carn and Down Surgery. So Chris will start towards the end of January. So we're going to have a short interregnum where we don't have a named medical director, and we're talking about how we fill that gap. The prioritisation group will be up and running in January. Clearly, it's not going to be as developed as it will be this time next year, but it will allow us to make tricky decisions using the leadership of our clinicians across the county to help keep our heads in the right space.
And Chris will be part of that development.
So he will be part of the development. We're going to, we've got access to his diary and we're starting to put things in, but very equally good. Carn and Downs don't want to release him early, and neither do West Cornwall Hospital, which I absolutely understand.
Very good. Everybody happy? And thank you, Helen. Okay, so let's move on now to item 7. So I can see we've got John Groom on the call and Rachel. Who's leading on this discussion?
I'll just introduce John.
Okay, so if I can just before we get on that, we've got a little bit of time. So we don't often have too many strategies coming to us. You can't have that many strategies, but this is the development phase of the next strategy for this vital piece of work. So we've got a good 20 minutes, Rachel. If you want to, with John, make sure that we cover this off to your satisfaction, please.
Thank you very much, Chair. Just to introduce this and just remind the board and for members of the public this particular item slot that we have on the agenda. One of the discussions we had early on in the board is as part of our big transformation programmes, our reconfiguration areas under Transforming Care for Cornwall, is that each board we wanted to have a key spotlight on each of those over the course of the year. but also as key products or key components of those reconfiguration programs start to come through, that actually it means that we can have those products coming through here to the board and a really good understanding of what that means for the people of Cornwall and the Isles of Scilly. I'm delighted John's with us today. John Groom is our SRO for our elective recovery programme and works with the Planned Care Board to help take forward the important piece of work that ensure that we can improve our access to planned care, and both in terms of the reduction in waiting times but also in the localisation, and two of the schemes that John's going to talk about today are exactly that. So John is just going to talk through a little bit around the current position on planned care, and then our key development areas which we are really excited about, which is our diagnostic treatment centre and our elective surgery hubs. So John, thank you so much for joining us today, and I'm very happy to hand over to you to take colleagues through this exciting stage that we're at.
Thanks, Rachel. Good morning, everybody. Before I start, I'd just like to thank partners within our system for helping compile this report. And as we get into the detail, hopefully we'll be able to demonstrate a significant amount of collaborative working across both the entirety of our system and also with some of our wider partners outside of the Cornwall Isles of Scilly footprint. So I'm going to take it as that people have read the paper. The paper really covers off three areas. The first element is a quick sit rep on where we are in terms of our current performance. The second element is a description of where we are with our community diagnostic centres programme of work, and the third element is elective surgical hubs programme of work. In terms of Rachel's intro, and I'm really grateful for all of Rachel's support over recent months, what we have tried to do, along with all the other programmes of work within Cornwall Isles of Scilly, is bring into line all of our documentation to make sure that it is comprehensive and meshes with all the other work programmes in our system, which means that we're in transition with ensuring that our documentation and that of CFT and RCHT, where possible, all adheres to the use of smart sheets, which means it's a consistent presentation and means that anybody can pick up a series of information and run with it. So we are in process with that, which is why in the first couple of slides in the pack it talks about using smart objectives and references a consistent approach. I'm very fortunate because most of my portfolio is around elective recovery, and we have had a number of targets that have been in place for a number of years, albeit augmented in recent years, and you'll see those in your pack. And it's important to realise that we're on a journey with most of those, and over the last probably 9 to 12 months, the emphasis has shifted slightly from some of the national metrics that we've been given, whilst nationally they're still very focused on our overall activity levels. Colleagues will be very well aware that at the moment the focus is predominantly on 104-week waiters and 78-week waiters for our system, and I guess we'll touch on that as we get into the discussion. What I'm very fortunate in is that we have a team of commissioning managers in the ICB who work very closely with colleagues like Doug Riley and Richard Andrejek at RCHT and Tom Lillyman at CFT to develop services that allow us to improve our diagnostic rates. That's basically the CDC work programme, and also where possible segregate our hot and cold work through the use of things like the elective surgical hubs programme of work. And obviously we've had successes around cold sites in the past in terms of what we've been able to do down at West Cornwall, and no doubt as we get into the presentation we'll talk about our ability to maintain cold elective capacity while we are in a extreme period of operational pressure in relation to UEC pathways of care, and I'm sure that will come out later on. So really what I'd like to report is that the CDC programme is going ahead as planned. The CDC opened officially for business in the first couple of weeks in November, and we are bringing online the additional modalities that we need to do. There are some conversations ongoing with regional and national colleagues in relation to further developments along this 4 or 5 year programme of work that we've got to do in relation to that. And only this morning, Nikki Hughes, Tracy Coles and myself sat down with Helen Crick from the regional team to look at the independent sector element of the offering around augmenting our diagnostics, which involves a letter of intent to engage with, but not necessarily buy into, a range of services that the independent sector can provide for us going forward. And that is a regionally procured solution, which we will be able to dip into if we'd like to. What we need to do locally in relation to that is to work out, once we've got all of our own diagnostic assets up and running, whether we actually need additional resources or not, and whether, if we do need additional resources, that is for a surge period, or whether we need to maintain a higher level over a period of time, recognising the national targets about diagnostic rates. I'm really glad Patrick's in the room with you today, because obviously a big enabler for our CDC programme of work and our overall diagnostic agenda is the workforce. And I think it's common knowledge that we have a challenge in Cornwall, but it's a national challenge as well, about recruiting the right members of staff to support our systems. And I'm incredibly grateful to Richard at RCHT, because he's put in place a novel trainee apprenticeship programme to try and grow some of our own staff, which is really exciting, and is one of the reasons that we've probably got as far as being a leader within the Southwest and nationally in terms of pilot sites, because when we've been challenged with, well, where will you find the workforce from, we've got a bit of a solution, but it still remains a challenge. Elective surgical hubs from a cold elective capacity point of view is a real win for us, and recognising we've got colleagues from Devon in the room as well. Clearly Bodmin is the site that we're starting that at, and we have had some conversations with our Devon colleagues about utilising floor space when we are not using it, and in the first instance we are intending to focus urology and gynaecology at the Bodmin site. We've recently had the visit from Tim Briggs around Girfton HVLC, and that went very well, and I'm grateful to Robin and Stephen, Alistair for hosting that event in effect, and Tim did impress on us the need for us to try and segregate our hot and cold work to allow us to keep going with the elective recovery programme. I'm just going to pause at that point, Chair, to see if there's any immediate questions.
Hi John, lovely to see you. We raised this, I think, at the last board meeting, but how much thought has been given to how ancillary sectors can support people to wait well? So actually there's a huge amount of evidence around the impact of peer support, opportunities like the HOPE programme, which we've already got in Cornwall, and other peer support innovations that I think you and I have talked about before in relation to work going on across the border in Devon. I think this is a real opportunity now to engage with the sector to think about how we can support you to keep people waiting well, and either potentially get them off your waiting lists, actually, because there are opportunities for people to take other alternative routes, or to at least have them prepped and ready to go for when you're able to deliver that elective care.
Thank you. That's really helpful, and recognising we've got some of that work ongoing. But if I can take an action to reconnect with you, that would be really helpful to scope that out a bit more. But I completely agree with the statement you're making, and I think over time what we need to recognise is that the assets we need to deploy now might be slightly different if we have a transformative model. And within the intro to the pack that you've received, we talk about our 4 programmes of work, and clearly a lot of that has to focus on non-traditional, non-acute, preventative, close to place type services as opposed to our traditional models. And I think we do need to factor in how far we think we're going to get with that. Otherwise we run the risk of trying to map out on paper traditional sets of resources that are both very costly and difficult to run, when there might be a more there is a more progressive model. So I'd absolutely buy into that, and welcome John further opportunity to maybe come back to this group to discuss that.
Thank you. We've got quite a few people wanting to ask questions, so if I could just ask you to be brief in your answers, I'd be grateful, John.
Okay.
When you come back to Emma on that, I'm sure all the board will be interested in the answer to that. So if one of you would be kind enough to circulate to the board whatever your findings are, that would be great. Okay, did you want to respond to that particular question?
Yeah, it was about Emma's question. So Susan Bracefield and I, in a previous iteration of working together, discovered somebody had been cancelled 4 times for an operation, only to find out he never wanted it in the first place. So I think there is something about how we link in enhanced supportive care into the waiting process, just to see if people have got proper informed consent. Would they consider something else rather than waiting a year and a half for an operation? So Susan, I just wonder whether you would be involved in the conversation with Emma, given your previous experience.
Yeah, I've just put into the chat, I think the ability to have a pre-ablement programme of work at place would be a huge coup for Cornwall. And it's not only the enhanced supportive care, it's also the shared decision-making piece as well. Really important.
So how are you going to talk?
I'll pick up with Emma. I think that's really exciting as an aspect.
I think that's fantastic. Let's move on. Andy, and then Steve, and then Emma, and then Debbie.
Very quickly, John, thank you. you mentioned Devon colleagues, and I'm grateful for that. You mentioned it in respect of elective surgery, and I'm just conscious of the 130,000 people in our population that receive their diagnostic services from other secondary care providers, and just really looking for some assurance that there's a process in place to make sure that people who get their diagnostics from UHP and from Royal Devon are not missed out in this process.
Absolutely. So thank you for raising that. So I'm very happy to take a more detailed response offline. But in terms of our capacity and demand modelling, and also our capability demand modelling, we've done some of that on a geographical basis. So that will be something that as we one of my other hats is to support the integrated performance report. Going forward, our integrated performance report will reflect need in place. So we'll pick that up as part of that.
A comment and a question. The comment is strongly welcome this. I think that the strategy is a great piece of partnership work that transforms access to diagnostic services and transforms access and increases capacity for elective services and for diagnostic services. And as John has said, we're seeing that at place-based opportunity. So particularly excited to see the elective centre at Bodmin coming online hopefully in the next 18 months. So really powerful, strongly supported. The question, John, is clearly we face some risks in this year achieving the requirements that we have. So is there anything in the strategy that you think there's potential to accelerate or bring forward to assist us in this year?
So Steve, that's a really good question, and thank you for the time you spent with me this week and also for some of your colleagues. So everybody in the room will be aware that partners have done a very good job of holding the line about 104-week waiters. We are, however, in a dialogue actually today in relation to some potential concerns about our 78-week wait position. And within that, there are 4 or 5 specialties that are of concern to our regional colleagues, and we're speaking to Ian Warden later on today about that. Steve and colleagues kindly went through with me the current set of schemes they've got in train to mitigate some of that risk. And I think, Steve, it's fair to say that you and I have a number of irons in the fire to try and deliver on the required level of activity to support the 78-week position. However, we need to, via the insourcing programs of work, understand the quantification of the benefit there, because we recognise there is a potential shortfall in activity that is required before the end of the year. If that happens, Steve, I'm expecting to come back to initially probably Transforming Care for Cornwall, and then F&P, and then up to board to describe a further mitigation, because there is a chance that we will need to do more than we are currently doing within our existing ESRF schemes, as an example, to mitigate the shortfall that potentially could result at the end of the year. So there's still a little bit of work in progress. I'm not trying to dodge the question, but I think we have to quantify the added value of the excellent schemes that RCHT and others have put together already, and we'll do that over the next 4 or 5 days.
Steve, I'll come back to that point, because John, I'm going to give you a heads up now. In about 2 or 3 minutes, I'm going to ask you the question at the very end of this. What do you and Rachel have as your number one ask from this board? So have a little think about that in a second. Debbie.
Yeah, so I'm proud to welcome this partnership. I think it's absolutely fantastic to see our community hospital sites being now used as community assets for the whole population. One, I think this is a great paper, but a great development. I had 2 questions. One was a slight ouch moment for me, because I heard the recommendation that we should separate hot and cold, but actually part of our UEC longer term ambitions is to move from a minor injuries unit provision on our Bodmin and CRCH sites to more UTC, urgent treatment centre specification. And although the demands aren't going to be massive, I think we would lose an opportunity if we absolutely boxed this in as only cold and elective facility. So if I could just ask you to bear that in mind. I think it does provide us also for an opportunity to start moving towards things like one-stop shop for dementia diagnosis, stroke memory assessment for those people that absolutely need the co-located clinicians, multi-professional team and diagnostics. So again, I really welcome that, but query, would that risk if we only looked at it as cold? And then my final point is welcome the conversation about pre-ablement, and in that, could we think about whether there's a role for IAPT and managing long-term conditions. We know we're not meeting our IAPT access trajectories. We're building more capacity to meet the national ambition, and in some areas, people on the waiting list have been offered IAPT as a positive and constructive support.
Before I go to Rachel and then Simon, did you want to feedback on that?
Yeah, it's just something around the place-based nature of these services. So I know Dale's staff and Will Howe from a North and East perspective are very excited about the Bodmin campus development, and GPs around that part of Cornwall would like to be fundamentally part of shaping it. And in that, they'd quite like the diagnostics to be done in Cornwall before people go to Plymouth for the procedure, which means that our people get a better service rather than us asking them to go all over the county. And the same principles around West Cornwall. And although Camborne and Redruth really sits in the west, it is a facility that provides access to Truro and the surrounding area. So there is something about how we get the GPs around the table early on around these place-based developments so that they're fundamentally shaping them.
Okay, Rachel?
Thank you, Chair. So I was just going to come back on the point about what more stretch can we do this year and just cite the board on the work that's happening, which is looking at where we started the year in terms of our current levels of performance, and from the things that we're currently funding and mobilising through the elective recovery fund, how far that will get us in terms of the things that we've got absolute confidence of. And I think that would be a really important point through the planned care board to then say what is the shortfall and where can we think about either more we can do within ourselves or what we might need to buy in to do more to end the year in a better position, because it's not only what we deliver in this year but also our start point for next year. But and it's that's a bit of assurance that we've asked for as the ICB.
Thank you, John. Thank you for that. And we've had lots of discussions, haven't we, planning this year and into 23-24 for obvious reasons on elective recovery in particular. So I just wanted to underline the point, and this is a national issue and also a local issue for us, and that's the impact of COVID, etc., over the last 2 or 3 years has affected the volume of people we can treat electively, which has dipped in the last 2 years, and we're bringing that back up in 23-24. That's going to be one of our major focuses, isn't it, as a ICB and through our services. What are your thoughts on what we're going to target next year, because that's going to be one of the biggest benefits to our local population in terms of reducing waiting lists, etc.
Absolutely, and before I answer that, Simon, Debbie, apologies if I wasn't clear. So obviously one of the reasons we cited the CDC from a diagnostic perspective at Bodmin was so that it could support our UEC agenda there as well. My comment about the hot and cold was the hot and cold surgical, so apologies I wasn't clear about that. So Simon, to answer your question, and again I'm grateful for support from colleagues like Joe Davies at RCHT, what we need to do over the remaining months of this year is, as Rachel's alluded to, work out what is a realistic output from our internal assets, both in terms of activity, but also the workforce. To answer your question, John, the thing that I would be most interested in is a proper understanding of the capability of our existing workforce and the capability of any workforce that we've got coming online. That then allows us to understand a realistic output for the end of this year and the start of next year, which then allows us to understand if we need to commission services from alternative providers. It also allows us to consider the succession planning route, which would take us down the route of moving some of our services into place to allow us to have the right staff located at place, rather than sometimes, because it's what's in front of us, perpetually dealing with what's the current coalface and potentially recruiting into existing roles, which then have a kind of 10-15 year lifespan. Now that's great if we recruit people into those roles, as long as there is an understanding that they may well be delivering a different level of service at a point in the future. So that cultural shift will be really helpful, and within that cultural shift we need to make sure that we sustain particularly CFT and RCHT as thriving organisations. So this is definitely an all arms approach to deliver on that. But to come back to your point, Simon, I think it's an extension of what Rachel said, which is that we need a realistic understanding at a specialty level of what is the art of the possible within our own assets, recognising operational impacts that happen. And I know this board has previously discussed the challenges of balancing UEC pathways with cold pathways, and therefore what we need is a system agreement in relation to what is in effect a production plan, which tells us how many resources we think we need to deliver certain levels of activity. And Simon, I'm very grateful for the conversations we've had this week about thinking about how we can form a view on that.
Okay, so we've got 3 or 4 people who want to ask. Again, if I could ask you for brevity, please, in terms of your responses. Neil first.
Thanks, John. On page 9, the CDC overview, 2 of the aims are around contributing to reducing health inequalities and delivering a better, more personalised diagnostic experience, on the basis that the way we're trying to take forward strategy now is people's needs, place and services around them. I welcome the location and the way this is happening at place, but there is evidence nationally that people with health who suffer health inequalities slip on pathways of diagnostic by being unable to access these issues, and that's particularly for people who are working hard at a time of crisis cash-wise for them. And I hope that you will engage with place-based teams to look at how they're looking at health inequalities and how that will impact people's access to diagnostics.
Just to add to that, I met our vaccination team yesterday. So we've got the highest vaccination rates for COVID in the country, and that's because the way the team work, flat matrix, they go into places and they ask people in the place what's the best way of getting hold of people who don't turn up for vaccination. I think that approach around diagnostics would be really helpful, because our hard to reach people aren't hard to reach if you know how to get there, and we need to use our community assets to send us in the right directions.
Okay, I'm going to start to wrap this up, but got 3 or 4 people who want to ask. So Steve was next.
Just briefly, and it follows on from Simon's question about what else we can do as a system to be ready for next year. John's mentions Professor Sir Tim Briggs, the National Clinical Director for Elective Recovery. And one of the things he was very clear on in the visit that John's just described is the importance of re-establishing St Michael's Hospital as a fully elective orthopaedic centre. So the current intention is that that would happen from April 2023. And what that really means is the trauma ward, which was moved to St Michael's Hospital as part of the trauma response, it's our intention that that returns to Royal Cornwall Hospital at the start of April, so that gives us more capacity for orthopaedics. I think that's particularly important because orthopaedics is the largest challenged specialty from a waiting list perspective. So Simon, that's one of the key things that can be put in place. If we were able to accelerate that, then that would make a difference in this year as well, but that's constrained by the urgent and emergency care pressures that we continue to face. The other aspect, Simon, could be, in addition to all of the things that John's described and is in the strategy, the potential for more use of the independent sector, perhaps on a temporary basis, to give additional capacity to help address those aspects. So there are some key things that can potentially be progressed towards the end of this year or into next year.
Okay, thank you. So just before I ask Tan, who wants to make a comment, Patrick, I'm going to come back to you in a second, and then Martin. When I asked John about what would be the ask, and he said it's a workforce issue, I'd just like you to start to have to think about how you might feedback on what we might do to answer that. But Tan.
Well, that feeds perfectly to this point, which is that place will form part of the workforce strategy, and has to form part of that. Obviously, there isn't going to be huge amounts of extra funds, so it's going to be about how we all work together across the system to make those places work.
You want to make a comment, Patrick?
Yeah, I think John's request is 2 parts. There's a short term and a longer term. For the longer term piece, the approach we'll be taking to workforce planning is that the diagnosticians chapter heading in the workforce plan for the system will be a key element alongside many others. For short term, I think we've got to get specific about the particular needs that would help us achieve those goals in the next year, working with the teams on the ground, because there aren't new people coming in the short term.
I'll ask possibly the 2 of you, when we get to part 2 and we have a discussion about workforce and that kind of thing, you might want to raise this again as a discussion point. Yeah, Martin?
Thanks, John. Yeah, we had this paper or similar at Finance and Performance and obviously supported it. One thing that we talked about a bit that I'd just like to raise again, the locations and geographies felt sensible, but I think we're still working sort of in the absence of our estate strategy. We've talked about lots of different things, development, St Michael's, West Cornwall Hospital, etc. Have we still got that piece of work in train? I think we were going to look at the totality of what we've got and perhaps have a plan about what we hope to develop in the medium term.
We're talking about purchasing a strategic estates service that allows us to look at the current plans we've got, because I think the plans for West Cornwall and Bodmin and St Michael's are fairly well progressed. What we haven't got is a plan for the rest of our estate and how we can use that to emancipate either additional capacity or indeed to work out what we do with it, because estate is costly in itself. So Simon and I'll pick that up as a piece of work, Martin.
Simon?
Is this automatic? Yeah, okay. This doesn't need a response. I think it's more a reflection that slide 4 of this deck for me is probably the most significant, which is obviously the outcomes crisis we're facing in terms of where we were in 2020 in terms of weights compared to now, which is really insightful to see it. The point being, I think, building on Steve's point, how will these services specifically bring down those specific lines? And what we've got is a series of outputs with these CDCs that are hopefully heading in the right direction, but will they change the outcome, which is slide 4? And, you know, Steve's example highlights where the biggest pain points are, but I would also say the cancer weights obviously as well. So it doesn't need an answer now, but if this is capacity helping in specific areas, e.g. elective surgeries, urology, gynecology, but not where the pain points are, it's not helping us with slide 4, which is what we're going to be held to account for.
So I'm just going to make an observation, then we'll see if we can wrap it up, which is I'm delighted you raised that, because it's where I was going to come at the very end of this. This is an excellent piece of work, colleagues. Great progress. I guess the piece of information that I may have missed is we have the statement of where we're at on slide 4, both from March 20 and September 22, and then you go to slide 5, you get to sort of like the must-dos. But what we're lacking is the trajectory that we could scrutinise over time in our committees. So John, maybe one of the ideas that we need to think about is not just where we're at and then the ultimate ambition, but actually the trajectory and the journey of getting there, that we could monitor our performance by line, which is, Sanj, I think your point on this, because if not, it's a great ambition, but how can we take assurance that we're actually going to do it, and at what pace?
So we do get very heavily performance managed on this by our regional colleagues. So those trajectories are in existence. I think what we haven't got is the mitigation plans for when the trajectories fail. So my personal view is we are going to have to do some outsourcing. I'd like to negotiate it now so we know which pathways our patients will be going on and what concierge services we need to put in place for vulnerable people to travel out of county and feel safe doing it. So we will look at that, and as part of our recovery plan that we'll bring back in the next iteration of this, we need to have the plans A, B, C and D.
Thank you. And I think that's a fantastic, Kate, because I think the one thing that was worrying me when John was making the point about workforce is some of these things can't be a light bulb that you switch on overnight, and therefore it's going to take X period of time. What are we going to do between then and that moment? That's for me about the planning exercise of the trajectory that goes, there's the ambition, but how are we going to get there, and what decisions do we need to make? So just to finish off on this piece of work, just before I offer up to John to have the comment, anything else, Rachel, you'd like to add?
Just to give the board the assurance around our outsourcing that was linked to the piece of work I mentioned, we're looking at the run rate we've got from this year and what we'll achieve through the current scheme. From our assessment so far, we will have a shortfall on that. So we are already exploring actually our wider independent sector, because you're absolutely right. It's a collaboration, as John described, between our NHS providers and the independent sector, and there is more that we can certainly go out on that, and that's our ambition, John.
So, Simon, can I just ask, you gratefully made the point about the planning for next year, and you asked what would be the ask that, you know, from John and from Rachel and colleagues that you would want. When might we, Rachel and John, get some feedback from you in terms of the asks that you want to give us, whether it be financial or other planning exercise? Is that something that you want to bring back to us in January or February, or what's your timeline for coming back to this? It's such an important area, Rachel.
I think it aligns very, very well with the joint planning work that we'll be going into in January. It's part and parcel of that, and then brings in the interrelationship with all of our pathways.
Everybody
okay,
happy with
John?
that? Yeah, thank you.
That's absolutely fine. That would really mesh very well with what we're currently doing.
Yeah, fab.
Excellent, everyone. John, anything else you would like to ask the board?
Chair, no, thank you. I think we've covered it sufficiently. Thank you very much.
I'm sorry if I was cutting you short, but
no, it's fine.
It's now on time, which is how we like to do things. Thank you very much, John. Thank you.
Bye, John.
Thanks, John.
Thank you.
So just coming back to therefore the recommendations on that paper, I take it, since everyone looked like they were in violent agreement to everything on here, that I can take those 3 recommendations as approved, yes?
Yeah.
Lovely. Thank you very much, everyone. So moving on, now in terms of the Director of Public Health annual report, of course, what with Rachel being off ill, and Al, thank you for alerting to me on that. In terms of, I think what we chatted is that we would, unless the board wanted to do this differently, was to take it as noted the report, and then reach out to Rachel Wiggleworth when she's well again to say, what would she like to do next? Would she like to come back at a future point? Is that acceptable to people? Or Al, did you want to do it differently?
No, I think that's fine with me, John. I think just noting really for the board that this is a statutory requirement that the Director of Public Health produces an annual report. It's an independent report, so it is actually for information today to board, and also really just for board to consider it. And consider the advice and recommendations in future discussions moving forward. But as you say, Rachel is off sick, so if there are any comments or questions that need to go back to Rachel, really appreciate if that could be taken offline or, as you said, at the next meeting. Thanks.
Well, thank you. Why don't we do this then? Why don't we just, I mean, you'll have all have read it. Are there any immediate questions that we want to either discuss or Trudy to log that you could then feed back to Rachel? Does that work as an approach? Yeah. So are there any questions or issues that people would like to ask about the report? Tan?
It's not a question, it's a comment.
Yeah.
It's to say that I know that the experience of working through the COMF programme was extremely well welcomed in the voluntary sector, and this ideas about power and how you empower at place has given us some really good learning for some of the place-based discussions that we need to have.
I just wanted to welcome the real focus on community assets in the report, and I think that's something that we should commend the Director of Public Health for. I think there are a couple of things that we as a board and our associated organisations do need to note, because it links into some of the other conversations we're having. I think there's something around commissioning for outcomes and collaboration as an approach going forward, and I know Rachel and I are working together on that, which is really good. Co-designing the solutions with people closest to the problems, that's really important, and again we've talked about that in Carol's Citizens Engagement Committee, and that's a real issue I think we need to come back to as we look to co-design the ICS strategy over the course of the next year, that we really do get out into our communities, working through organisations who are closest to communities, and then I guess there's something else around the integration within the voluntary sector, but also that integration and collaboration between ICB and wider council services, and it's great to see that being picked up through the ICAs at place, where we've got representation now coming into the ICAs from the wider Cornwall Council services, because there's nothing that Cornwall Council does that isn't about fundamentally improving the well-being of our people and communities, and I think that's something that it's really exciting to see Neil and MD colleagues picking up locally.
Debbie?
Yes, so I really welcomed the report, and actually it's really timely. It's always great when things triangulate in a way. So I had the pleasure of meeting 4 way ahead, think ahead social work trainees, and that's the accelerated programme for social work that we are following in this county. And as part of their academic work, they received a presentation from a Professor Martin Webber at York University. And he has been developing a connecting people model and a research evidence base to support that. And he has connections with Cornwall. So myself and Julie Gripton have had conversations with him, and he'd be really happy to actually talk to us as a system in the new year about how we might be able to run alongside our communities work a co-located evidence base that we could take forward so that we could build future evaluation into measuring the impact. So I think this is a great public health report and a foundation for us to move forward on.
I think that's really important because I went to a Health Foundation roundtable and there isn't any evidence that integrated working actually makes a difference. If you look at high level integrated working, if you start at multidisciplinary team working, which is integrated working, there's loads of evidence. So it's strategically how we import that evidence into the things that we do. And it was the thing that Emma raised around people nearest to the problems usually know the answers. That's called quality improvement methodology, isn't it? So I think all the time we need to challenge ourselves around using the evidence we've got in the way that's right for the place that it's in. And some of our place-based development strategies for next year, we do need to emancipate what people want and need on the ground and use some of our community engagement mechanisms that people who live in our county do outside of our county to start getting some energy behind it.
Okay, any other observations? Just a feedback. An excellent report. Simon, can I just ask, are there any implications that we need to take into account for planning finances next year?
Not that I'm aware of at the moment, not that it's significant.
Okay. So, Al, I think one of the things you might want to feedback on is if there are any financial implications out of this. You know, I talked earlier on about having a timeline to next year. If this has implications and we see this as strategic priorities, then it ought to be fed in early on so that you can trade off, you know, how you build all elements of this in.
I think it will have implications because remember for True North we talked about financial channel shift.
Yeah.
This speaks to financial channel shift.
Absolutely.
So at the moment we've got the money in the statutory agencies where we're saying that the intelligence for emancipation sits in the voluntary sector and in communities. So how do we start giving the true levers for change to the people that can extract the change? And I think it's a part of our financial strategy. We should be walking the walk rather than just talking about it.
Do you agree with that, Emma?
I just wanted to pick up on something that Kate talked about and Tarn raised as well, and make a bit of a bid for the importance and innovation around the human learning systems approach to change management and quality improvement. I think the comp funding has really taught us that continual iteration and co-designing between providers, the community and people who are funding services makes a huge difference to the way that services are delivered and reshaped and improved. And I would personally really like to see that. We're building that into all of any of the bid writing and contract management that we'll be doing. And I'd really like to see that being built into some of our into our commissioning approach as well.
Gen Q work that was at the Confederation thing that we went to, they showed the human learning system connections and the ordinary system connections. Millions in human learning system, very little in normal systems. So building on that would be great.
Patrick?
I just wanted to add on that theme, so maybe not direct financial implications, definitely direct workforce implications. I was at one of the population health management workshops that Rachel has been convening, and what was coming out loud and clear in that session was the kind of mindset capability shifts for our workforce across the board to work in that way, especially in the way that Emma's describing. So we are factoring that into the development of the system workforce strategy that we're going to be bringing back to this board in January.
It's up again later on in the day. So both Emma, can you remind us, and Patrick, Simon?
I was just going to highlight in terms of the channel shift discussion. I joined a meeting with Rachel and ICA colleagues a couple of days ago where we had an in-depth discussion about how we make that happen and how we develop a strategy that moves us in a direction that the resource is getting closer to local communities. So we're on a journey, I think, over the next couple of months to try and ensure that does happen and that we see the service benefits as a result.
Thank you. Thank you. Ali?
Yeah, thanks, John. If I can just come back in. So first of all, can I just thank colleagues for the excellent feedback, which I will make sure that Rachel gets, and I'm sure it will make her feel a lot better when she hears that. I'll text her right away, actually. And I just wanted to echo my agreement with what colleagues have said so far there in the conversation. And certainly from my perspective, this paper doesn't have financial implications, but if we let this and take the advice and the recommendations, it will influence the way that we make decisions moving forward. It will influence the model of care that we come together to develop with our communities. And from my experience, co-production, and this is where I think some of the financial implications can come in, co-production is more cost effective than developing services that do not meet the needs and deliver outcomes about what matters to our residents. We will talk later, and we've already touched on several times today around some of the outcome frameworks, but actually getting into communities, understanding what matters on a micro and a macro level to individuals and their communities is a much better use of our resources moving forward. So, and we'll have those conversations as and when things develop. So thank you again. I'll pass on the feedback.
Lucy starting in the new year, who should help, which is excellent. Okay, colleagues, I think that we can say fantastic, thank you, and pass on our best wishes to Rachel. Ali, thank you. Okay, so other than that, was there anything particularly I needed to... So what we're doing in the minutes, truly, we've had a good discussion. I think we've noted the context and we support the recommendations. Everyone? Yep. Done. Thank you. So let's move on to Carolyn, please, on the joint forward plan.
Thank you, Chair. So I've taken the paper as read. I'd like to open again with a thanks to partners, because this is obviously about forward planning and planning into 23 and 24. And we've had some really good conversations and workshops about our planning into 23 and 24 and into that joint forward plan, as well as the integrated care strategy, because as you'll understand, they're all running parallel at the moment. So this paper is the first in a series of updates with some recommendations. The points to kind of pull out from it is that the board's aware of the approach. We signed it off at our last meeting. We're looking at putting our planning through 3 gateways. Gateway 1, which is to review and confirm the proposed priorities for the joint forward plan. Gateway 2 is the initial proposals for the SMART objectives and the performance levels for the joint forward plan and system operating plan. And Gateway 3 is to review the proposed service changes and efficiency initiatives. This paper is specifically about the completion of the Gateway 1. There was a mention in the exec summary about national guidance setting out requirements, but as yet we've not received those. We keep getting promised it'll be this week, it'll be this week, it'll be this week. We're still waiting. No, that's the operating plan. That's the operating plan on Christmas Eve. So as you can anticipate, we're not waiting, we're getting on. This paper, as I say, is confirming all of those things. So there are 2 recommendations and a note with this paper. But again, the other thing that I would just like to kind of bring to partners' attention, because we talked about it in the elective recovery and about how we would monitor. Although this is Gateway 2, a lot of the SMART objective work is already in train, and partners and colleagues have signed up to those, and we're beginning to pull those together. So obviously that will be part of the next paper. But this is just to let you know that obviously the Gateway 1 has been complete. Obviously we've confirmed our strategic priorities. We've talked about the elements of the clinical priorities identified for 22 and 23, but also for the recovery that's got to continue into 23, 24 and 24 and 25. So as I said, it's quite a short paper. You'll see from the appendices that you've got the priorities that we've agreed and talked about, and everybody should be very familiar with these now. We've included the timeframes, and I would just reiterate again, such tight timeframes, which is why I'm so grateful for colleagues who have been part of these kind of planning sessions and workshops that we've had, because it is such a tight timeframe. And then Appendix 3 obviously is around our financial context. Now again, colleagues around the table here who've been at the System Executive Group will have been cited on these. Claire Bryan has kind of gone through these with us in some detail. And what I'd also just like to add into there is that because we're really aware of the financial context and obviously going into the planning arena, There is a finance sustainability group that has been set up with our finance colleagues, our operational colleagues, our workforce colleagues, because we're doing this together. We're not doing it in isolation. And the first group meets on the 13th of December. It's going to be a monthly group. And as I say, it's made up of finance community colleagues, digital estates, ops and performance, and kind of workforce. And that group is going to look at all of the things that we've kind of put into the back appendix about what can we do further to meet that financial challenge that we have. So, Chair, that's the update from that particular paper. As I say, quite a short paper. Most people should be aware of it because we've discussed it at the previous board and at the System Executive Group.
Okay.
So there should be no surprises.
Simon?
Thank you, John. I was just going to update on the sort of financial planning that sits alongside that, and this is a set of fantastic framework for our planning in 23-24. We have a timeline that sits alongside it that you could expand on. If you look at the table on page 6 at the bottom, it talks about the gateways. Within that, we've got detail that supports the financial planning, and I thought it'd be useful to give a bit of an update on that. So the focus to date has been to become a lot clearer about what the underlying position is for each organisation in the ICB moving into next year, and that's the dialogue that's been happening with our trust to clarify the challenge we're starting with before we make any assumptions about growth, increases in activity, etc., etc. So that's the initial stage that we're planning to land over the next week in terms of our understanding. That exercise has thrown up a whole range of questions that you'd naturally expect to appear this time of year, which is questions about what assumptions there are in individual services that have been stood up over the past 2 years, whether they continue or don't continue. So there's a discussion to be had, which we'll be putting in place prior to Christmas to clarify some of those issues, and then that'll make the view of our recurring underlying position really clear, and any decisions that we need to take alongside that about current service levels for particular areas that have been stood up over the past 2 years.
Can I just stop you, Simon?
Yes.
Colleagues can't hear us, Pete. Yeah, but they've lost the room.
You don't want me to repeat all that?
Yeah, both Emma and Ali are saying
struggling to hear us.
And then Ali's put we've lost the room.
Oh. That might be.
Jane, can you hear us? No.
Carol, can you hear us? Okay, so clearly we have an issue. Let's pause for a second and we'll wait, Peter.
Can you do it through the medium of dance, Simon?
I can. I think they're probably all aware of what I said.
Silence.
Hi. Tim, can you hear us?
No.
No? You can't hear us at all? Well, this is interesting.
This happened at the Devon ICB. Oh, did you hear that, Jane?
Sign language.
Can I just check? Can all of us on Teams hear each other?
Yes.
Oh, no, we
can hear you, Ali.
now. Can you hear us now?
Okay. You just needed to talk, Ali. That's what it was.
That's what it was.
You'd gone to sleep.
Okay. Simon, do start again.
I'm going to start. I'm going to summarise, and I won't rehearse what you've all agreed to in the planning process. So I'll summarise. In terms of the financial planning, our expectation is in the next 2 weeks we've got a really clear view of the underlying position moving in from this year into next year. There's a set of meetings that Rachel and myself will be setting up with each of our trusts to run through the financial assumptions alongside the operational assumptions around services that have been stood up and that are in place for the current year. And alongside that, just to make the connection.
Again, Simon.
Right.
Sorry. Just lost you. You're coming to be the bit, so
So I move this nearer. Does that help? Can you hear me now?
Yeah.
Oh, there we go then. Apologies for that. Okay. So we get there eventually. So I'll summarise really briefly again. We're establishing clarity on the underlying position for this year. There's meetings being set up with each of our trust organisations to run through operational position and finance position of planning for next year. Our commissioning colleagues with ops colleagues will be finalising a view on the targets that we're looking to deliver next year, preempting the national guidance but then being refined by the national guidance. And we've also kicked off some work to look at the activity modelling view of next year when we look at elective and non-elective to take... I'm not sure I can do anything different unless it's just my microphone.
Just keep going.
Is it just that mic, maybe?
Yeah. Can you hear me?
Can you hear us?
Yeah.
Thank you very much. Hello. Does that work? I'm hoping everyone will be really clear about the planning arrangements financially for 23-24. How many times shall we summarise? I'll do my media training, say at least 3 times. So I will try and summarise. So what we're saying is, in the current month, we're being clear about the underlying position for next year, and we'll be taking that through SEG in the meeting after next. We'll also be sitting down with our trust colleagues to work through service plans and finance plans as they stand currently, to take a view, are they recurring issues or not recurring issues, and therefore affects the baseline for next year. Commissioning and operational colleagues are sitting down to establish their view on the targets for next year, electively, etc., to have something against which we model our service level view for next year and establish an initial plan, operational plan and finance plan for early January. So I would hope that we'll be in a position to do an update to this board in the private part in January, and we'll be taking those updates through SEG. That's my best.
Sorry, I didn't catch that. Can you repeat it? Okay, moving on. Sorry, that was unfair. Susan, sorry.
So just, and I'm in danger of hijacking Simon here, or a gotcha moment, but I also think we need to look at how we take this through the clinical, our clinical groups, because there is something around productivity and efficiency. I think that clinical leaders can add to this.
Okay, cool. Yep. So one of the things which I'd like to just get, I've got two points. One here is, I think we need an update on page 6 of the appendix, because it talks about Gateway 2 effectively coming here today, and yet the Gateway 2 is not ready yet. Again, you know what I'm going to say, but I'm going to say it. Can we not just have the targets, but the trajectories as well? So we can use our scrutiny committees to ensure we're supportive of supporting you to actually help get there. I think that's important. Thank you for raising that in terms of the alignment for finances. But I got asked a question during the week, Carolyn, and it's relevant to not just this paper, but to the next one. When it's called the joint forward plan, who's it joint with, and what's the difference, particularly as this is in a public session, what's the difference between a joint forward plan and an integrated care strategy?
So the joint forward plan is owned by the NHS and partners. The integrated care strategy...
Which part? These partners?
Partners sitting in this room. So with mental health, with the RCHT, CFT and ourselves. So it's
and the council?
So it's NHS and trust
Thank
partners.
You. So it's an NHS strategy.
Integrated care strategy is NHS, local authority and partners.
So voluntary
really clear.
Voluntary sector. So if we're going to spend money in the third sector, it would be part of this, wouldn't it? Because we'll make assumptions around allocations for the offset or the purchase of NHS services. That would need to be included in this.
Yes, because this
I think actually I do get it, but I'm just trying to sort of rehearse it, because if you happen to be somebody who's a member of the public with all these strategies, you think, what's the difference between one and the other? Okay. Debbie.
Yeah, so it was, again, noting this is a public paper. If you look at the clinical priorities and you were a member of the public, you don't see urgent and emergency care named. Now, I know we have it included in flow and within intermediate care, but I guess if you're a member of the public, you might not
That's
see
a fair challenge.
UEC as a priority, which is
It certainly should say flow and discharge, and maybe in brackets
Ambulance
incorporating,
holds.
that kind of thing. There's something, Debbie, if I can just take that up as a wider point. I think there's sometimes a language which we understand on this side of the fence, and when you try and use this through a lens of somebody who doesn't get it, some of the numbers and the metrics might make sense to us, but aren't easily. So you might want to think about, again, when Lucy comes, another set of eyes coming in and viewing it from a different perspective. That's all in terms of the metrics.
Goes back to my point with Emma though earlier. So we need to be communicating in a way that people know what we're talking about.
Yes.
Okay. Jane's hands up, John.
Jane, sorry, couldn't see your hand. Go for it.
Yeah, no, sorry. Just to say, I think actually, so that Carolyn doesn't have sleepless nights waiting for the refreshed joint forward plan or the long-term plan. Apparently that's not going to happen now. So I've been involved in a couple of roundtables, and I think actually in the mental health update yesterday, they said essentially rather than producing a new set of long-term plan targets or areas, we're to stick to the ones we know and essentially carry on. So I think that's probably quite helpful, but I suspect there will be further stuff that will come through the operating plan, particularly in areas such as mental health.
Okay, so keep calm and carry on is the message. Steve.
Yeah, thank you, John. A really helpful paper. And this might be a question for Simon. On page 7 of 9 in the local context section, the first bullet point talks about the potential for Cornwall and the Isles of Scilly to receive lower than average funding growth in future. And I'm mindful of the extraordinary challenges that we face in Cornwall and the Isles of Scilly. And certainly I would be advocating for higher than average funding growth in future to our region. I just wonder, firstly, if you can give us a bit more context on that, and then secondly, is there anything we can do as an integrated care board which would help support us being in the strongest possible position for future funding allocation?
So I have been in discussion with the new regional director of finance, Jeff Buggle, on this particular issue, and I think given the position we're currently working with this year in terms of continue to aim to deliver a break even, his expectation is that we won't be put under any pressure more than any other patch in 23-24. So he is still assuring me that we'll be in a fairly good position next year, and they'll support us accordingly. So I'm not expecting it to be a 23-24 issue at all at the moment in the recent response I've had from my colleague.
Thank you. If I can just go back to Jane just for a moment. At our last board meeting, we agreed the Peninsula Committee, if you recall, as part of this joint forward plan. Part of the reason why I was teasing out the question about who was the joint with, clearly nearly a quarter of our residents actually go to Devon. How are you making sure that the Peninsula Committee and the way in which the joint forward plan is linking up with Devon?
So Jane and I are yet to have that discussion. So it was one of the actions that was given to us by the Peninsula Partnership Group that's about to be stood down with a Peninsula Collaborative Board about to be stood up, which potentially could be a joint subcommittee of each ICB, subject to us discussing it. The point I wanted to make though feeds into that, in that clinicians spend our money by the choices that they make, the services they provide, and the recommendations they make for patients. So there is something around going to the experts, be they in communities or be they in providers, to engage them in the process of efficiency and productivity and the removal of waste. So I think we need to get a clinical stream alongside all of these plans, with them telling us where we would go to make the best savings for our population. And that feeds beautifully, Jane, into the Peninsula Partnership Collaborative.
Okay, colleagues.
James's hands up. Sorry.
Yep.
Yes.
Go on, Jane.
Well, I just want to say, I think there's two bits. There's also the need to bring together Carolyn and Simon and Bill Shields is the lead for Devon, just in terms of so we can do that compare and contrast around you know, it's not just about specialist or acute services. It's just making sure we've got that alignment and for our operating plans and our ICS plans as well. So I think that's the sort of the peninsular acute services work. I think is almost a separate item. But I think Kate, you and I've got a catch up tomorrow, hopefully.
Very good. Okay, so let's go to the recommendations, everyone, please. Are you happy to approve the priorities developed in the 5-year forward plan as in Appendix 1? I assume yes. Approve start driving the plans and mitigations as in Appendix 3. Okay. And noting the short time frame, I agree. It's very short. The fact that you're actually going to align them. Now, the only other subsequent point that comes out of it is I was making a note on looking at my diary. The next 2 board meetings we've got are the 12th of January, and then we've actually got the 9th of February and the 9th of March. How confident are you that on the 12th of January we're going to get the Gateway 2 priorities back? Yeah. Because yeah. So if I could just ask all colleagues, when you're thinking about the forward plan, and I'm thinking about the finances and that kind of thing, you'll work back from the fact that board papers need to be out by X date in a week in advance of the board, and you start to think about if we have to rejig FMP committees or whatever else to support you in that. This is such an important 3 months coming up that we work with you as non-execs to make sure we support you to get it through the journey. Okay? Okay, so that's that paper. Thank you. So I tell you what I'm going to do. I'm going to move to item 10, but I'm going to invite Kate first to introduce the integrated care strategy. Because the presentation, from my perspective, the fact it came out at 5 o'clock last night hasn't really given some colleagues the opportunity to really read it and comment on it. So Kate and I and the non-exec spoke this morning, so you might want to just introduce it and then we can hand over to Rachel.
To contextualise, this is our first integrated care strategy for Cornwall and the Isles of Scilly. And it brings together the work of our integrated care partnership, so broader engagement with the council, with the ICB, looking at a small number of things that we really think that we can turn the dial, make improvement on over the next 3 to 5 years. Ali Bullman and myself and Rachel O'Connor and Rachel Rotherow have been, well, I haven't been doing very much. They've been doing loads of work around how this is all brought together. This will be our first iteration of what our integrated care strategy will be. And I fully expect we'll get lots of feedback when we submit it at the end of December. We would like to invite a small subgroup of our board to meet. Sanj would chair the meeting for us, and people could be co-opted onto it to agree the final draft that we submit at the end of December, so that when it goes off, it goes with our full agreement. We want to make sure that we use the data we've got to identify the populations with the greatest need, because our job as an ICB, in engaging with our ICP colleagues, broadly the council, is to make sure that the people who need the most in Cornwall are the ones that we focus on as part of increasing health, happiness and hope across our county. So that's the genesis for this piece of work. If Rachel goes through the presentation and then... I'm just thinking about the timeline for this, because this is one of those rare things which it's not just within our gift to do this. So I'm not asking you to agree the recommendation now, but when we're about to go through this, I'd like you to think through when we get to the recommendation. So if I'm really clear, this is a draft piece of work that has to go up the wire sometime before Christmas. Is that right? No, 31st of December.
Okay, sorry, the end of the month.
Yeah.
Sorry, the end of the month. Okay, so there's something here about, we were expecting in this paper to have had, and there's a huge amount of work going on, so this is not a criticism, all right, to try and get something out to you which I don't think you've had enough time to really consider. So I think the change to the recommendation is that we want to empower you with the FMP committee to effectively take away any observations you've got, but Sanj, for you to invite all colleagues to your Finance and Performance Committee to actually, who would like to have the debate about this, because you haven't had time to consider it, but be invited to your committee, and what we do in the recommendation is empower Kate and that committee before the end of the month to actually make the decision, because we're going to have to do that. Does that sound like I know it's a compromise, but are you comfortable with that as a direct, not agreeing it now, but as a So don't feel under pressure at the moment to have to answer in this next 20 minutes, is why I've interjected here to this presentation. But let's use the next 20 minutes to get what we can out of it. So rather than present, why don't you just, because there's about 20 odd slides, why don't you just give us a highlight of what you think in there, and then colleagues respond to Rachel, because you might not have even read it yet.
So just in case I forget, it's F&P plus, because this
Yes.
isn't about finance and money.
Correct.
This is about, hope for our population. And the feedback KPMG have given us, because they've been working with us, is that the ambition we've got and the plans we're developing are ambitious, and they're in the right area. So I just want us to know that we've got external validation that where we're going is on the right tracks.
And I know I'm just going to double check that, but it is the mechanism that we're using formally as a board to delegate down for the wider group to be engaged through that group, which you're all invited to. Rachel.
Thank you very much, Chair. So I'll make some key points. There's probably one slide in a moment, colleagues are flipped to, that really talks about the essence of our integrated care strategy. So just a few things to kind of hold as you think through what we're trying to produce here as a partnership. It's very much come from the place of what can we do best together that absolutely looks over the next 10 years and how we can improve some of the most important outcomes for the population of Cornwall and the Isles of Scilly, and very much taking an holistic approach. And as we've been doing the engagement, a statement I've been making, which I will share here, is I know for some colleagues that people might have felt like we've been here before. I think the thing that's really different here is that this is a strategy that absolutely is set in our integration, our core role as an integrated care partnership and board, and very much set in legislation. And actually, as we go through the course of next year, this will be a key part of our assessment as an ICB from the CQC in terms of the ability to which we come together, the ability to which we have a good joint commissioning plan to improve the outcomes for local people. The second point I wanted to emphasise is very much where Kate led off. The absolute starting point has been our joint strategic needs assessment and the areas that we think we should have our collective ambition to do better by, and really focusing on the needs of the population. So that really informs the kind of what we intend to do together. We have also built on much of the pre-engagement work that's been done through the sector, through the places that we've been engaging with, and very much have used this as the opportunity to embed our True North priorities. So whilst we are describing in the strategy our life course priorities, we're also describing the True North as our key how, our key enablers. And again, I just ask you to hold that, because that's what's different this time round, is the how we do things differently together. That I think those True North priorities around left shift, around place, around people at the centre, and health inequalities really demonstrate for us. It is most certainly a draft outline that we produced at the end of December. I would like to take the opportunity to thank many of the officers, both clinical, professional, non-clinical in your organisations that have attended a number of workshops over the last month to contribute to that. And their input, their ideas, their ambition has been really powerful to see and to have in the room, and I think is a real demonstration of our kind of collective leadership and our compassionate leadership that we're seeing through those sessions. The draft outline will be produced in December. We will then go through that further engagement through January and February, where we will then be able to sign off then through the formal governance, as John described, our first draft of the ICP. And it is intended that this is regularly refreshed as the JSNAs are refreshed and as we see fit. And the final comment before I go into perhaps the key slide for people to see about what our intentions are is, again, I think something which is really different this time round is Rachel Rotherow, Ali and I are very focused on this being underpinned by an outcomes framework. And that outcomes framework bringing together what we have currently, which is our silo framework. So what we will have for each of the areas that we're seeking to make a difference on is we will map that back to the relevant outcome, which is a holistic framework across public health, across the NHS, across adult social care, that we can then not only set our ambition, but that should be how we use this live through the year in actually members of this board seeing how we are doing and how we are improving against that ambition. And we started that piece of work. I'm not sure who's driving the slides for me, but would somebody, oh, thank you. Would you mind flicking on to the next one, please? So just a few points from here to emphasise. We are very much taking a life course approach. This has resonated really well when we've been talking to both the public and to professionals, that mean that we are here for you for your first 1,000 days right through to your last 1,000 days. And we expect the quality, the outcome to be the very best through that life course, and that's our collective ambition. And that within that we can look at articulating specific needs across that life course when we want to address improved outcomes together. As we've gone through that life course approach, we've assessed those needs at each of those stages, and that's what's defined some of the key strategic goals that we want to make happen over the next 10 years. We will align that to the outcomes, and that's the basis of the strategy that we're developing. Next slide, please. Next slide, please. Next slide, please. Okay, so the essence of the key areas that we've identified through the Joint Strategic Needs Assessment and through our co-dialogue with colleagues fall into these key areas. So under our Start Well and our children and young people, very much we have an opportunity to do better on our first 1,000 days of life, and the great start that we help support our young people with as they are born into our places, particularly in terms of their improvement in school readiness and their developmental capabilities, and how that has such a great foundation for then their adult years and their later life. But within that, we know particularly what has changed over the last 10 years, and particularly through the pandemic, has been the increasing complexity that we have around mental health in our young people and their mental health resilience. And that's come through really strongly in terms of the outcome areas of an area, not just now, but when you look forward into the next 10 years, significant holistic work we can do together in terms of the health and well-being to support our children and young people. As we move into our adult years, not just in terms of our adult years, but also how that is a bedrock as people move into their last 1,000 days of life, is actually how we ensure the great prevention and avoidable ill health and determinants of health as people are in their adult years, and particularly through the lifestyle choices and the impact across our long-term conditions. And again, a secondary theme here, again, and a great start at the beginning of the conversation, the Health Watch report, in terms of our resilience in mental health through our adult working life, and what that means within units of families and carers in particular. And all of these have great themes with our work with the voluntary sector that we explored in our dialogue in the sessions. And then as we move into our later years of life, really strong areas in our Joint Strategic Needs Assessment collectively where we can do better. And I have to say, I think this is one of the areas where those frameworks really closely overlap and align, is how we support people to be as independent for as long as they can. But particularly what has come through is the importance of the support in people's communities around social isolation and loneliness, and how we connect people in their communities to support them as they age, and particularly as we support them in those last days of life. So we are yet to have, I think in the spirit of transparency, Chair, our Live Well working session. That is next week. So there'll be richness that comes through from those areas, and we're looking forward to that conversation.
Thank you. Questions? I mean, to be fair, you might not have read it, but thank you for the presentation that we've got so far. Any themes? I've got a couple of observations. Anything that you want to... Debbie?
So I recognise it's a huge amount of work to be done in a very short time frame. And also as we're emerging with our partnerships. Thus far. I just had a couple of specific questions, Rachel, if I may. If I go to slide 6, I absolutely recognise the Start Well, Live Well, Age Well. But when I get towards the bottom of the page, I'm reading the bottom boxes in a sort of linear flow. And therefore that infers that mental health and good mental health isn't a priority under the Ageing Well work stream. And I'm wondering whether some of these priorities in that bottom section are more cross-cutting across the lifespan, as you described it, rather than sitting in those very clear linear boxes, is my first question. And then the second one is a question for Ali, although it's directed at the local authority, although I know you've worked with Rachel Rotherow on this, which is on the last slide. We have the market position statement with the local authority being responsible for that and the time frame being a year. And I think that we absolutely know that we've got significant market challenges now. And I just wanted to ensure that we weren't going to be waiting for a year to get to an MPS before we do any stimulation or engagement.
One of the things which I think colleagues, you might want to start to think about post today and before that you get to meet as a wider group. This isn't an annual plan, the integrated care strategy, to be fair. It's meant to be a longer term strategy. I think one of the confusing parts are we trying to use an integrated care strategy to sort next year? And that's not the goal, to be fair. So I think one of the issues which I would ask you all to think about when you're considering this is what the Department of Health and Social Care actually want from our integrated care strategy. Okay, so I'd like you to understand what's in scope, because there's some lovely generic comments in here, but I'm looking at the Department for Health's guidance that asks us to consider health-related services, and I'd like to try and understand at what point the wider determinants of health are included in this. So I can see in your presentation you refer to, I assume, the Department for Work and Pensions Work and Health Programme when it comes to jobs. Yeah? So immediately we're already stepping outside of just NHS and social care in your slide deck.
So particularly where they link to some of our more vulnerable groups, John. So when you look at the outcomes framework, when we walked through that the other day, particularly for people with suffering from mental illness and those with a learning disability, there is definitely a really strong theme coming through actually where we've got more to do in terms of our employment opportunity to support those specific individuals.
So I guess the point I was just trying to raise is this is more than just the NHS and social care budgets in integrated care strategy.
So John, we're starting to place in terms of the outcomes. I think the budget conversation is a later point in terms of actually how we deliver this as a strategy.
I'll make my observations, then you can push back as you need to. So if we take something like workforce, which for me is a huge underpinning theme to be able to deliver some of this stuff, I'm sure that the Department for Health are going to want to see a really strong. It's nice to have those customer-led, start well, end well, that kind of thing. But if workforce is a key theme, it'd be clear to understand how we do that. And for me, as part of that, I'd like to try and understand if we get into the housing type of wider determinants, how does this integrated care strategy start to think about how we, either for individuals, I'm thinking of that unfortunate situation in Rochdale where that child died of mould in a flat. That's clearly an impact on us. Staff that we struggle to recruit because we can't find people for locations on them. That's part of a housing strategy. Is that going to be part of the integrated care strategy?
So certainly in terms of how this aligns with the health and wellbeing strategy, I think there's elements. I mean, Kate, do you want to take this question? Because I know there was a discussion yesterday about it. I don't want to misinterpret what you discussed yesterday.
Why don't you go first?
So Ali and I met and discussed this morning.
Okay.
So we think this should sort of like be boundaryless in terms of the things that need to be put in place in order to improve the health and lifetime chances of our population. If there are some issues that start to emerge around children growing up in areas of poor housing where we're seeing high levels of presentation for respiratory illnesses, and we think that the circumstances in Rotherham are likely to be found in Cornwall, we would be using the outcomes framework around who's responsible for that bit of policy in Cornwall, and then we'd be going to that area to say you need to respond to this. We have found this through our ICP. We need a housing response that says that young children will not be open to these dangers in their early childhoods. So that was the conversation Ali and I had this morning. Once we've got the mapping of who's responsible for what in an outcomes framework and our ambition through our ICP, we then know where we should be having the discussions around levering the right resources for our population.
Okay. Ali.
Yeah, thank you. So I'll come in on the comments that colleagues have made in a moment. But first of all, I just wanted to take a moment to give some recognition to Rachel O'Connor and Rachel Rotherow for the work that they've done on this at pace in quite a short time scale. And I'm just really grateful for that and the partnership working that's demonstrated. So I think there's something about how we map these outcomes. So there's a whole suite of outcome frameworks, and I'm not sure how visible they are. Can somebody stop sharing the screen? Because I seem to be on it twice, and I'm not sure if that's just the way it is, but it's disconcerting. So as we map out these outcome frameworks, the public health framework, the SCOF framework for adult social care, the outcomes for children, young people, and the NHS outcomes, I think we'll see where there's some codependencies. And Kate, you and I have taken a piece of work yesterday further to our conversation to develop that kind of recommendation to John as the chair of ICB and to the leader of the council around those roles, relationships, interfaces and codependencies between the Health and Wellbeing Board and the ICP strategy. So, and I think that's the work that Rachel are finalising at the moment. I know they were very busy redesigning the architecture of how we all work and report when I left them at County Hall a few days ago. So I know that work is in train. So I think, as I spoke to Kate this morning, I think there's something for us where if we're clear about there's a move in the wrong direction of our outcomes that we're monitoring through the ICP, we can ask the relevant people for some assurance around what's happening. You know, are there concerns around mold in properties? You know, what's our level of confidence and assurance? And we can start asking people for that information rather than, from my perspective, our strategy being so broad and wide that actually we're not really focused on what our priorities are and how we deliver those key priorities across health and social care and the public health sector. So I think there's absolutely a role around broader determinants of health. I think we need to agree as a system how broad that is, or how there's some overlap in some of these ways of working and how we work together on some of those issues. I'm really keen that we're clear about our priorities and that we start delivering some of these outcomes for our residents and the improvements that we want to see. So that's probably all I wanted to say on it, but just really grateful for the work and the partnership work between Rachel and Rachel on getting us this far. Thank you.
Okay. And one of the things that you referenced in terms of the conversations taking place between us all is, of course, the relationship between the Health and Wellbeing Board and the Integrated Care Partnership has still got to be flushed through, and whether we have one strategy or two strategies in the Health and Wellbeing Board and the Integrated Care Partnership. And just for me being able to note in the minutes, if I may, Trudy, I do want to refer you all back to the terms of reference that was agreed for the Integrated Care Partnership and what the mandate was given to that. So when you come, or if you want to go to the Sandra's committee, you might want to just reflect back into that and challenge yourself. Is it still what we said then, or do we want to make it something different? Because the real trick of this is, regardless of what the Department of Health say, although don't forget they will be marking our exam paper, as it were, it is down to us to decide what this is. And I think that's why really empowering, I'm hoping, Al and yourself through this, we can come up with something that works both for the councils, Ali, and for the NHS, and the implications, which is why I rather laboured the point earlier on about the joint forward plan as the golden thread that goes between them. Is that fair, Ali? Are you happy with that?
Yeah, no, I'm happy with that, John, and that's work that Kate and I started having that conversation this morning, and we'll be pulling together over the next couple of weeks. I think what will be really helpful is when we map out the outcome frameworks, John, because I think you'll be surprised how that is presented, to be honest with you, and that I think that will bring it to life here, because what the council isn't doing at the moment is putting into the integrated care partnership the housing strategy and things like that. So
agreed.
So we need to find that way of working, and I think I honestly, genuinely, from my experience, think this is quite straightforward. And having spoken to a lot of people and colleagues, I think everybody's saying pretty much the same thing. It's just being lost a little bit in translation. So I think we just need to pull this work together, John, and then we can move forward.
I agree, and I'll invite Mary, and then we're going to move on, actually. But I think the point that came out of yesterday was, by having an open dialogue between everybody in such a frank way as I'm delighted we had yesterday, we move away from the generics and we start getting into the meat of what these relationships are going to be, because from that we can draw lines through into budgets and decisions and things that we can hold ourselves to account for. Mary.
Thank you. I just wanted to say how much I appreciate, I think this thing is great,
the reference to support for carers of all ages, which includes formal carers, because without them we are in difficulties. I'm aware and welcome your comments about the accommodation, and the bits that won't show in some of the other council picture. For example, I look after about 170 beds and I've got 200 staff. 15 of those are Filipinos who've come over in the last few months. We've managed to provide them with accommodation at the moment. They are beginning to look out for their own accommodation because they want to bring dependents over who are not going to have been born here. They're not figuring at the moment on council tax stats because they're in a house of multiple occupancy. They can't keep on. We've got some British people in our accommodation as well. One of them's got a child and they're looking at overcrowding, not just the mould that you talk about, but there's lots of exploding families going to start looking who are all accessed in the care sector. We don't want to lose them out of Cornwall.
Agreed. Okay, thank you very much. So let's move to the recommendations, if I may, because there's a slight tweak to them. So we're going to note the current progress. So thank you for that. I can recognise everyone I've spoken to can see the huge amount of work and engagement by all parties in this, and it's such a tough ask, isn't it, when actually the exam paper's being written by the department, and we've got to find a way of making it work within that across so many different bodies. So thank you to you, and will you pass on our thanks to your colleagues in the council as well?
Most certainly, and I would also just say we are really trying to make sure it's got the flavour of Cornwall and the Isles of Scilly, both in the tone, and so it's very much ours, John.
No, I agree. So we're noting that. We've considered the outline of the strategy. Now, in the board papers, the recommendation was to delegate it down to effectively the chair, non-execs and Kate. I think what we're saying now is that through the offices of Kate and Sanj, that actually you happy with that, Trudy? Yeah. That what we do is we give the opportunity for that committee to set up whenever you need to support the journey of this, and that is that a problem? Go on.
No, I just wanted to come in. Steve had to go.
Yes.
He wanted me to say he's supportive of the approach through the committee. So
lovely.
that recorded.
No,
for,
thank you.
For the record.
Thank you so much. Because I think what's important then is everybody has the right and the opportunity to input into this. It's so important. So Sanj, would you kindly take that offline with Kate afterwards, as long as everyone's happy with that approach? Yeah? Agreed. Thank you. And therefore, I think the rest of the recommendations, Trudy, will take as agreed then, if that's okay.
Thank you.
Everyone happy with that?
Brilliant, thank you.
Lovely. Huge work. Thank you so much, everyone.
It's worth noting, John, that Ali's replied to Mary around a specification for accommodation with care and support by March the 23rd.
Debbie.
Sorry.
Kate, is for Debbie, yeah, not Mary. So I didn't answer the MSc question, so I just wanted to put in, and I put it in the chat box, that it's a refresh of the market position statement. And both Rachels, we have a collection of Rachels, have agreed to bring forward a specification of accommodation with care and support by March 23. So that's also a work in progress.
Okay, colleagues, thank you. So we're running a little bit behind. Just to finish off that point, there is a relevance between item 10 and when we get to talk about the Price Waterhouse piece of work, and then later on in part 2 as well, because some of these things have a golden thread of how we're going to do things. So we'll park that, but we'll come back to it later. So welcome, Kelvin. I apologise last time we cut you short. So you've got between now and 5 minutes. No, we'll give you.
Cut you short again. That's right.
We'll cut you short again. All right. We'll give you until 12 o'clock. All right. But please, can we draw a line at 12 o'clock, and then we're going to have a comfort break.
Yeah. No problem. Thank you. I did have some slides, but a few issues with the network here, so I'll make do without those, because actually I do know this stuff off pat. So obviously the papers, you've got the digital strategy for the integrated care system that we've developed through the course of this year. So the piece of work came about because when I joined joined RCHT and CFT as dual Chief Information Officer, developed a strategy of providing organisational level strategies for RCHT and CFT, and an ambition to actually develop a digital strategy for the whole system. We delivered those strategies for the two organisations, and actually, as the Integrated Care Board concept began to be developed, there was actually a national ask to develop strategies and costed portfolios for digital across integrated care systems. Now, interestingly, nationally, that was quietly forgotten when the start dates were slipped a little bit, but we actually decided to carry on with a piece of work because we thought it would be really helpful. And actually, a number of you will have seen the presentation that I gave at the True North event, which was a pretty much complete version of the strategy at that point. We've just done a little bit of finishing off in terms of some of the engagement and the articulation of the elements within the strategy. I think probably the key things really to draw out from it as a piece of work is it fundamentally has been developed in partnership with everybody across the system. So we conducted a range of interviews with different partners, structured it around, as I say, the national What Good Looks Like framework, which is an expectation of how we will operate digitally within the wider aspirations for integrated care systems. But actually, really importantly, we didn't just work on that national framework. We said we actually want to apply the local context for Cornwall. So we've actually also built in our aims and objectives as an integrated care system. And really, I think the themes there that come through in terms of recognising our rurality, the importance of actually being able to work remotely, to deliver care in remote settings, come through in terms of the broad approach that we've taken there. I think, as I say, in terms of the key things to draw out for everybody in terms of the conversation, it's really shifting our dynamic from one of our organisations deliver care, and actually as citizens we tend to be passive recipients. We go for a meeting with our GP, we get onto a healthcare pathway and work through that. Really in line with the whole digital revolution that's happening everywhere, it's about actually giving people control and visibility of their care. So the things around the patient portal, starting quite small at the moment in terms of visibility of appointments. We're just starting to allow people to make changes to their appointments. We're integrating it with the NHS app. But the ambition really is for that to be a single point of entry for anyone to access any services, and really to be the place you go for a persistent relationship with health and care, not a sporadic one in terms of when you come for a particular appointment. So that's absolutely fundamental to the strategy, and actually using that route as well to gather more information on people's needs, not just again, when they fill out a survey when they've had an episode of care. Underpinning all of this, of course, is actually a fundamental shift in terms of the digital technology that's needed to deliver it. We're moving as a system from it's a relatively low digital maturity, not because we don't have innovative technology, but because it's not been joined up effectively enough in the past. So actually we've got islands of innovation, but really now there's an integrated architecture here which will allow us to join up patient information more effectively, allow individual systems to work with that joined up information, so that actually you don't have to keep telling your story over and over again when you have a new care episode. And I suppose really before opening up to questions, I think fundamentally, although this is a strategy setting out our ambitions over the next actually 5 to 10 years in reality, we're not waiting 5 to 10 years to have these things. It's actually a blend of a very large portfolio of work that was underway anyway, but actually set out where it's actually consistent with our strategy and we're delivering aims and goals over the coming years. And of course, COVID landed just as we were getting going with all of this, and actually far from slowing things down, it's actually accelerated a lot of what we're doing and actually allowed us to raise our ambitions in terms of what we're trying to do in the coming years. So that's really just a bit of a scene setter in terms of, as you saw, a very large document in terms of the overall content, but actually something we're really proud to have produced.
Thank you. We have a fridge outside that's arrived, so if you can't hear us, we'll try and speak more loudly. Questions? Sanj?
Thanks, Kevin. Really a lot of detail in there, and I suppose my question is around the things identified around digital illiteracy as well as digital poverty, and you do highlight the fact that 13% of people in Cornwall, up to 2018 have not accessed the internet. the ageing population and some of the things that are in there to try and close that gap. I think it would be good, I guess, to monitor how that improves, because, you know, for example, on supporting people, you've got a blend of, I suppose, supply side advancements in digital connectivity in terms of HR and recruitment being on one platform, but also the demand side, which is not staff improvement around digital, but actually our customers, our patients, and how those numbers improve for them. And the second point, I think, is something I heard in a BBC interview, is one of the frustrations people have with the NHS is the need to repeatedly share information with different providers in the system, and it feels like they're telling their story, sometimes painfully, multiple times. And I wonder whether, is there something in this that with partners simplifies that through the use of technology?
So digital inclusion, actually, it's a really interesting topic in the sense of we all carry, I think, quite a few preconceptions around, I think, the rural challenges for Cornwall. So quite often people will say to me, well, there's no coverage in Cornwall. Absolutely, there are areas of poor coverage, but if there was none, of course, none of us would have a mobile phone. But actually, the mobile phone coverage, numbers of mobile phones in Cornwall are actually broadly similar to the rest of the country. A bit lower, as I say, in terms of home broadband, which might be linked to some of the poverty issues that you were mentioning, because actually the patient portal, which is already up and running in RCHT, we're getting some really interesting figures back in terms of first off, very high levels of uptake on that. So 70-80% of people who are offered the opportunity to join that are. And some of the highest levels of uptake are actually in some of our most deprived areas, so kind of Poole, Camborne, Redruth. And we think that might be because actually people are already effectively entirely reliant on their smartphones. So actually smartphones are more likely to be the primary digital tool than kind of old thinking around broadband connections. And then very, very quickly in terms of the data sharing, the Devon and Cornwall Care Record, which is actually already operational, is the fundamental sharing mechanism. So that is available to all clinicians.
I've been to a few talks recently on the digital social care record. I represent the care sector in Cornwall, and we're aware that there is an authorised list of approved providers of social care records. A lot of us invested quite a significant sum of money into ones. We don't want to end up finding we're required to buy another one because the one we bought isn't applicable or doesn't have a shared platform or whatever you call it. So I just want to flag up the needs. I don't know where Cornwall is in the social care sector as to the numbers who are actually digitally functioning on digital records at the moment. I know that we're probably behind the rest of the UK, which I think we've got to have 60% by February, 80% by 2024. And that's, CQC collects stats from us, asking us whether we've got digital social care records, but they don't ask us which one we're using. Mm-hmm. So there needs to be a message coming out sooner rather than later to tell the social care sector what the requirements are. And I think my role here is just to make sure, please make sure it's compatible.
Ellen, take that one away, if you will, and come back to Mary on that, if you will. Emma?
Thank you, Chair, and great to see you, Kelvin. So I suspect it's probably because these conversations have happened since this document was created, but just to reassure the board that we have made the link between the overarching strategy and the voluntary and community sector. I think there's a job of work for us to do as a sector to move much more towards a single system where we can, and particularly amongst organisations who are most closely supporting the health and care system. So that's a job that we're looking to do ourselves. And then how that can link into the Devon and Cornwall Shared Care Record so that we can provide that interoperability between organisations working to support you all and that patient interface as well. And the other thing I would say, so it would be great to see that reflected in the next iteration of the strategy, because I think that is an important conversation that's already happening. And also just to say, don't forget the role of the voluntary sector in the digital inclusion piece. That's a lot of the work that we already do around how we can support citizens at place to understand and be more informed and feel more confident to utilise digital access to a whole range of different services. So firstly to say Kevin, I think it's an excellent piece of work, and I've had the joy of sitting in a number of meetings with you as you've presented, and actually that's been I just want to play back to the board who may not have seen that wider engagement, just how grateful and enthused people are, because it opens up, I think, a number of solutions, not just in a digital world, but from an operational space and in terms of some of the outcomes that we were just talking about. I think it's really nice to see this piece. We've just followed the latter item, because you can see how the true north priority around our connectivity, around our PHM and our overall strategy, this is such an important part of how we make that happen. And I did want to link to board members when in part 2 we talk about the 256 monies. Actually, that shows a real example of where we are jointly investing in some of the key component parts of this strategy early on, particularly across the social care and health sector, to make the first foundations in this getting off the blocks.
Thank you. Ali?
Thanks, John. And this might sound slightly contradictory to what Rachel's just said, so apologies for that. First of all, thank you, Kelvin. I think this is a really robust digital strategy, and it covers a whole range of things, doesn't it? From tech interface with our public to cybersecurity, data protection, etc., which is great to see. However, my observation was that it's quite light on social care. And I checked in with my lead on this morning, just to see whether she was aware of this strategy and whether she'd been involved in it. And I think that we've got a bit more work to do. So I think that there's some interdependencies with some of the work that's going on in social care, particularly around our tech strategy and some of our self-service and demand management strategies that we're putting in place in the council. And I'm not quite sure we've quite got it linked up as it could be. And I'm really passionate about digital and tech solutions. So I'm happy to have a conversation outside of board, but I think it's a really good strategy. It's just a bit light on social care if it's the ICS strategy. Thanks.
So in fairness to Kelvin, so Kelvin's doing a system...
I'm not knocking Kelvin.
Yeah,
I'm not knocking Kelvin.
Kelvin's doing a system director of a digital role within not the time to do all of it. So it is something that we definitely need to pick up to make sure that we're giving Kelvin the platform and the time to be able to make sure that he knits us together well.
I'll come back to this, but before I bring in Patrick and Simon away to comment, but it is badged as the ICS's piece of work, and then you reference, for example, Trelisk's patient portal. I think there's something here about making sure that we're clear on when this is actually a system solution and when it actually is part of the operational teams and then badged as this, because it's quite different. Because there's some really big of scale things here. And the final thing I want to say before I bring in Patrick, let Patrick and Simon and I do our comment, and you respond to everything. There's something here about doing things at scale, which sometimes are very back office orientated, kit and caboodle and that kind of thing. But I really love this, really love it. For me, this is one of the leading pieces of work I've seen in terms of customer journey. That won't surprise you to do this. So I'm absolutely loving this to pieces. It's just sometimes I think we then got to think about it from their touch points in, not just seeing it from our collecting out. And I think for me, if we could take this forward and see this as an approach that we use generally, I think it's absolutely fantastic. Patrick?
Comment. I really like it as well. Format and content. For someone who's working on a workforce strategy, this is setting quite a high bar. So thanks, Kevin, for that. But the comment was offline. It'd be great to talk about the overlap between workforce and digital strategy. Thanks.
Yeah, I was just going to say briefly, and you could also respond to it, that again, I support the strategy. I think it's really clear, really helpful, and can make a major contribution to improvements across the patch over the coming years. Selfishly, but on behalf of our population, I also think there are many streams of funds that support digital, and it may be worth us exploring more where we can attract more funds from to support what's an important agenda for us, because it's well understood nationally that this is one of the things that's going to make a difference. So we need to pick that up in our dialogue over the coming weeks. Thank you.
Okay, so I just want to lay the opportunity of tea and biscuits in front of you. Okay, all right, but we're going to take it in the order of Mary first. Please.
Just to say, the NHSE presentation yesterday said that the ICSs would be able to pay for it to care sectors, and I'm sure you don't look as if you knew that. For those who are
I'll leave that with my good friend on the right, and we'll pick that up. But just take that away. Thank you. Tim, you wanted to make a comment.
Yeah, thank you. A couple of points, if I could, John. So firstly, hi, Kevin, and thanks for this. I see how it's carried on from what was presented at True North, and again, love the customer journey piece in the middle. For me, as a regional provider and representing SWAST here, that piece about people understanding what's happening with them, that patient portal experience is absolutely key, and absolutely fundamentally that information sharing across care settings and wider, into the voluntary space, as we've heard about, into local authorities. So that's where I think that's really where we're going to make some real big game changers in the coming probably half decade, if we are honest about it, because if you think about Devon and Cornwall Care Record, it's taken a while to get to where it has done, and there's a lot more it can do. The other thing I was just going to say is, perhaps in response to what Simon said, I think be a little bit wary, I would suggest we need to be, in terms of digital has the power to transform. However, it was one of the first places that the central NHS went to and cut in order to fund pay awards. So, there is a little bit of a dichotomy in there in terms of saying, we know this can actually change. We are in an information age. We know this can make a real difference to our colleagues, to the people that we serve. And yet sometimes, the money doesn't always flow in the direction that we'd set the ambition to. Thank you.
No pressure, Simon. I'm sure you'll resolve it for us. Thank you. Debbie, you wanted to have a comment. I'm so sorry, Debbie. Martin, you wanted next.
Yeah, just a brief one really. Didn't want to jump in. I wanted to commend or request or enhance, the business, the BI sort of bit, because, I think now that we're collecting better and richer data, or will be, the more we can work to, I suppose it's a way of personalising care, but looking at, where we've got duplication, where things work well, getting into clinical outcomes even, that will help us to both, drive efficiency and personalised care, I think. So getting that investment in and getting us to have rich information out, I think is something we massively need.
Okay, thank you. Debbie?
To commend Kelvin for the piece of work, and I think this is a demonstration of how I'll just be a provider for a moment, because Steve wasn't here for the beginning of the item, but we're very fortunate to have Kelvin as our dual CIO across CFT and RCHT, and now to be sort of lending him into this space to bring his expertise to pull it all together. And I think it's an example of how we are sharing expertise at system level. So I'd like to thank you personally, Kelvin, for a great piece of work.
Thank you for that. So I'll lead us to the recommendations, but just before I do that, I'm reflecting on, I think, Martin, you asked the question earlier on about the estate strategy, and there's something about having the capacity to do this kind of thing. These are really big shifts of our way to do things, and Kate made the point about you sort of doing this between your lunch break and on a Sunday evening. So Kate, can I ask you just to take away and think about how the system actually makes sure it has an investment in IT digital, and whether it be the directorate or whatever else that goes with that, because if we don't get behind this, it'll be a lovely presentation, it'll have £2.50 in the budget, and then it won't shift the dial, and this feels like a major enabler. Would that be a fair summary? I'm seeing lots of nods. Is that a fair challenge?
Yeah, that's great. Right, so I'll pick up with Kelvin and with Debbie and Steve.
You're keeping us between our biscuits, so go for it. Emma, last time.
Can I just add into that then the point that Martin just made about intelligence, because that is a major, I think, benefit that comes off the back of this.
So if you can capture how we do digital and BI, and then come back with that.
And Kelvin's got views around data architecture and data scientists rather than analysts.
Would you be happy if we were ambitious in this space?
Absolutely, I think I'm ambitious in all the spaces as maybe as within the document. So, very much so.
Kelvin, thank you. This is absolutely immense. Thank you very much. So, sorry, Neil, did I?
Just to add to what Emma said, just to be really clear, we've talked about intelligence, but I hope that really means the potential, although we don't want digital capability to drive how we do it, if we ask the right questions in terms of outcomes and experiences, given what you just said about health inequalities and smartphones, which really interested me, I think there are great potentials here to know we're doing the right thing for people and for them to feed back.
Thank you very much. Thank you, Kelvin. So just before we break, the recommendations. We're noting the digital strategy and the cost of portfolio. We've just said it's an enabler. We note the SEG members endorse the digital strategy, and we're agreeing the progression of the digital strategy, and we're adding really those other points we just talked about in terms of you coming back with solutions to be of scale on behalf of the system. Thank you. So in terms of the break, we're now running 15 odd minutes behind. Do you need 15 minutes or can you take 10?
Depends how many women's toilets there are. We
may have to do 10 minutes, so let's aspire to start at 15:15, but if not, we'll defer back to 20 past. But we'll have to be compact and bijou on our updates. Is that okay with everyone?
Yes.
Thank you. See you in a bit.
Thank you.
So, welcome back everyone. So last month we had Pricewaterhouse come and present their interim findings to us. And I think what's really important that we've been able to use the time from that presentation to now to actually get their full improvement programme. I'm delighted to see it in part 1. And it comes with all the elements of what I call the wiring bits behind it. So, okay, we only have a few minutes really on this because hopefully everyone would have seen it. It's been through SEG, is my understanding.
The governance improvement plan hasn't been through SEG, but the terms of reference,
yes,
SEG and TCPC have been through SEG. Hello?
Okay, so I'll tell you what I'm going to try and do to be helpful here, because I mean it's an excellent piece of work, but it's quite chunky. We went through it at length. I think we had 40 odd minutes of it at a high level. Are there any particular questions relating to the Pricewaterhouse? So let's do it by exception. Are there any particular questions relating to the specifics on the Pricewaterhouse report? Okay. So then when we move on to is the terms of reference. And I'm going to come back to the improvement programme that came out of the PwC in a minute. But so my understanding is that the SEG terms of reference and Transforming Care for Cornwall are agreed.
Yeah, they're agreed at SEG last week. We've made a commitment to review them 6 months in, just to make sure they're working for us. And Ali, who isn't on the screen at the moment, has asked whether the representation at Transforming Care for Cornwall can be changed from Kate Canali to her, so that she's the council representative.
Very good. Very happy with that. So the key theme, I'm hoping, bearing in mind the senior executive group has talked about it, is just to spend a couple of minutes on the key theme that came out from PwC in terms of having a improvement programme aimed at sort of the governance bits of that. And Martin, you've kindly agreed to chair that piece of work. So is there anything that you would like to share in terms of your thoughts on what and how you think this might go to the next stage?
Well, John, I mean, obviously we're setting up the group, which will, I suppose, give a bit of governance and structure to the recommendations from the report and how we flow those through into action. It's clear from what we've done today, some of them are going to be short-term, fairly easy fixes, whether governance things around terms of reference or, things like socialising our objectives or our strategies. Obviously, some of them are a bit more longer-term or medium-term, perhaps, on the recommendations about working together, changing ways of working across the system. And I think, we're already doing some of that. We've seen from Kelvin's report just now some fantastic work about how we are working together across the system. But the group itself will look at those recommendations, follow them through, have an accountable director, and report back, I think, periodically through to this board, ultimately, to show how we're getting on with that.
Let's not forget that we actually commissioned this piece of work. And from the perspective that the seat that I sit on as one of the 42 ICB chairs, when I look at some of the other 41, actually we're quite well ahead. When I've been talking to others, they say, like, we're still yet to start that and you're about to review it. So your version of it. So actually we have done some great stuff, but there's always great learnings that you can take in things. So I think we shouldn't see this as criticism, but we should see this as focusing on how we do best practice and challenging ourselves to how we do the next stage. So thank you for that piece of work, everyone. Anything else you'd like to add?
I suppose the Good Governance Institute came to talk to us as ICB chief execs last week, just with a general flavour of what's happening across the country. And John's right, us doing a review of our governance early on is good, because people are struggling with the things that we were struggling with. But equally, there is a comment that people are making very complex governance arrangements for things that could be simplified. So I think for all of us, there's a plea from me that if we are starting to put very complicated arrangements in place, we just need to say stop and make it as simple as possible.
And the machine that feeds it as well needs to be simplified as well, because it just consumes people's time. Okay, so let's move with everyone's support straight to the recommendations unless there's any other observations. We're happy to move to the recommendations? Yes? Okay. So, just lost my place. There we go. Turn the page. So to approve the continuation delivery of the improvement programme, and Martin, you're going to chair that. We've just spoken about that. To approve the SEG terms of reference has been agreed. To approve the terms of reference for the Transforming Care for Cornwall, and all the meeting structures that are in here and annotated. We trailed them last month and they've been through and are now being agreed. The one that I'll pick up, which I said we would touch on just briefly when we're here, is we referencing in here something that which is effectively a joint commissioning group, which we've still yet to work out what that is, but we'll pick that up later in the day, particularly when we get into the section 256 and that kind of stuff later on this afternoon. But I'm just referencing it such that at this point you notice that it is our intention to be setting up that initiative.
So the bit I want to be clear about on page 59 is that we've got formal board subcommittees and then there are groups that feed into them. They are not formal board subcommittees. We just need to be very clear that they are meetings that at some part of their business will relate to those committees. We may at some point in the future establish another joint board subcommittee between Devon and Cornwall around a provider collaborative and integrated cross-county working over acute care, but we are yet to work that through, and when we reach that point, Jane and I would bring this back to this board and also to the Devon ICB.
Yeah. Trudy?
Yeah, can I kind of just go on helpful to minute that whilst they are not formal subcommittees of the board, if they're listed under those committees, we would expect those committees to sign off their terms of reference.
Through you?
Yeah, that's
yeah,
fine.
yeah. It comes through you and all our normal governance structure, but it's kind of the committee then has cited them. That's why there's only a very few. There's a limited.
I think this has caused part of the confusion about this. So I think if we look to our chief exec and accountable officer to recommend those to the relevant committee chairs, takes them through them, then they come back to here and they can be signed off.
Yep.
Is that if we can really minute that as a journey, that's really important. But let's take note of the fact that a lot of these have not had that, therefore they are indicative at this point and not set up to do it. So they're only set up once they've had their terms of reference agreed, effectively. If not, they work under Kate as the AO.
And Carolyn will pick that up, John, so that early next year, all of these groups, we need to make sure the terms of reference are A, fit for purpose, B, have been signed off, and that they come to the next available ICB board so that we're clear that we are established formally.
That will form part of the PwC improvement programme as well.
Absolutely.
Kate?
And later on, in case we forget, just please remind me, we are going to need to talk about both competency capacity to do some of this.
Yeah.
Because there's we can't just load more work on to people. If we're going to do this properly, we have to have clarity as to competency capacity to do this fundamental piece of work. Okay, everybody happy we've captured all the recommendations there? Yes?
Yes, Carolyn,
I am, thank you.
Yep, very good. So moving on then to people's updates. So let's start with the non-execs, if I may. So Neil, may I start with you, please? Anything from yourself?
Okay, so I'll take my report there as read. Problem is, to some extent, that the timing of ICA meetings means that one's just happened. So it's probably worth just bringing up to date the fact that the development session that we held in November, which was excellently facilitated by Juliet Ferris, has brought together some documents and thinking that were discussed at the last ICA committee meeting, and in some ways bring together the future vision under. It's interesting, sitting in ICA committees gets a bit confusing because actually we're already beginning to emerge into an integrated care system partnership type of working, but we're part of the ICB, and therefore we have to remember that in terms of what we're doing. But so what we're looking at is strategic visions for 10 and 5 years, but a 1 year coming up 23-24 operational plan, which we hope we can inform the board in due course. I'll come back to you, Rachel, as to when we intend to do that. But some key things are emerging as to what we need from the system to deliver this. And this is very brief. A commitment of all organisations to break down barriers to integration, as in shared roles, shared clinical risk, and adequate resource to be able to implement change, and the capacity for senior leaders at place to be able to engage and plan strategically. We're doing that. Every other meeting now of the ICA is a development meeting, looking at strategic ways forward of how we're going to make things work, which I think has already reaped rewards. So there's now a clarity around what we need to do and who we need in leadership. And effectively from in January we'll have another development session which will look at how we need to empower and support leadership teams at place, and what clear commonality of quality outcomes we need to work for, and if possible that those are shared across the system. Okay. So that's where we are with ICAs. Do you want to add anything taking that forward, Rachel?
Just the spirit of that meeting I think is superb. I'm glad Tan's noted, and I think we've got from that day development session a good kind of early cut of what our strategy is for place in its widest sense, place and communities. And the timeline, Neil, so we keep everything aligned in the spirit of the conversation. I think as part of our joint plan, actually that becomes where we can bring that back through the board so it all comes together.
Okay. Tom?
Yeah, thank you. So just to note really some good coordinated work around cost of living. This is going to be something that's going to really stretch our workforce this winter. Good coordination on industrial action. And Patrick, can I come to you for just to note anything on ambulances, please, that we've had since then in a second. And also to note the good workforce work on the SDC. Most of our work last month was on strategy and developing the strategy and really taking that forward. It does need to read across to place. It does need to read across to digital. So we will be focusing on our kind of headline metrics around recruitment, retention and wellbeing staff, profile of our staff in terms of agency and agency, age and agency, sorry. And also to look at organisational development and leadership. We will be looking at other core themes around housing as well, which is already coming out in the strategy.
Very much. Any questions for Tana?
Could I just comment? It's on the two really. So before I came here today, I was listening to Surrey Heartlands talking about their implementation of the Fuller Review, which is in part workforce, but it is in part integrated primary care and place development. So I think it would be really good early next year to bring back what we're doing around implementing the Fuller Review. And Debbie, I met this morning two of your hip hops, one hip and one hop. So one's the head of integrated professions and one's the head of operational somethings. It's just hip and hop stayed in my head. So we're starting to see place-based managerial development. So it'd be good to draw the two together so that we are clear on a place around what assets we've got, be they statutory sector, be they voluntary sector, be they people who live there, so that we're doing strengths-based development.
And John, just one more point. Is all of this, of course, is being done within the vacuum of we still don't have the National Workforce Strategy. So once we have the National Workforce Strategy, we will obviously have to revise our strategy accordingly.
Or the other way around.
Or the other way around.
Very good. Tana, anything else?
No.
Thank you.
So I was conscious that I didn't look at primary care. I'm
going to come back to you on,
yeah, that's fine.
On that answer. Okay. Oh, actually, are you done?
Yes.
Yeah, let's do you next on that. Now.
Okay. It was, again, reporters has read, there are... the key things I think for you to be aware of are that public-facing GP appointments are now live, and it's just that comes with a quality data warning in a sense, and that the Primary Care Directorate are fully aware of the implications for that for practices. There has been, I think it's been outed in Cornwall through Cornwall Live already, and I think the LMC MMA wish to comment, but have made some answers in terms of that data. But it's very difficult to separate that from operational issues, okay. So be careful. And Kate mentioned the fuller stock take. We've put a link in there to it. I think it's really important for board members to be aware of that, and the recommendation that ICBs must support primary care in its widest sense. That's a message I really wanted to make clear.
Emma.
Thanks, John. Thanks, Neil. Yeah. So a really good piece of comms collaborative working between ICB colleagues and the LMC to preempt what we knew would be challenging data from the point of view of accuracy. It has not helped general practice or wider primary care family one iota, having to manage that and the morale sapping consequences of that. But it's one of a long line of issues that colleagues have had to deal with, unfortunately. So thank you to everyone for their help in supporting that in a fairly seamless way. I think the other thing I just wanted to highlight at the moment, and again, it is causing this week significant operational issues, is around the Strep A and just the consequence that that's having, not just on general practice, appreciate on the much wider family, but it is a real red flag at the moment. Practices are reeling from understandable issues with parents thinking that the children are perhaps suffering something that they're happily not in most cases, and that in and of itself is causing sort of further infection issues, really. People desperate to be seen. So just wanted to flag that, and really just two more things while I've got the microphone on the wider sort of fragility issues. Colleagues will be aware that the general practice alert status as part of Opal escalation is now live across the Duchy. We're in week 3, about to report the position. We will say that from an LMC point of view, I've just had confirmation this week that we have the highest number of GPs in pastoral support that we've ever had since we started recording, which is a piece of evidence that sits sort of and speaks for itself, really. So I'll just leave that there, but to thank everyone, certainly my ICB and primary care colleagues, for all their support in trying to manage us through this continuing challenge, and thanks to Neil for all the work you're doing.
Thank you for that contribution, Emma. Andy, you wanted to go?
Just to say, particularly on the Group A strep and the pressures in general practice, with your permission, Chair, I might update the board in part 2 on some operational issues that are possibly too sensitive to do in part 1.
No, fine. Thank you. Susan?
And it's just on that point, the SCC stood up its primary care cell this week, working with our comms cell, working with our children's cell, just so that we've got a coordinated approach to some of the issues that Emma's talked about and that Andy will talk about in part 2.
So, well, I can see you on the screen, Carol. Would you cover off both your committees, please?
Thank you, Chair. Unfortunately, we've not met since the last board. So the December meeting of the System Engagement Committee had to be stood down. So that's meeting now on the 16th of January, when the new Director of Engagement is here as well, which is good news. And then the Quality and Pathways of Care Committee is meeting on the 19th of December. We have made a concerted effort next year to resynchronise these meetings so that they are providing a sufficient up-to-date information to board, appreciating the same conflict that Neil will have, which is sometimes there may be additional information, but we haven't met since the last board meeting.
Thank you very much. Shall we move on to Sanj?
Thanks. Just a few things by way of, I think, what's relevant to share. One, and a highlight, I think, is Cat 2 mean response times and Cat 1 mean response times are both down since last month, which I think is really something to commend the system, but particularly, you know, RCHT, SWAST and others who've contributed towards that, as well as the fact that I think the key metric we've talked about around 30-minute ambulance handover is up from 13.5 to 23%. So again, heading towards that goal of 100%. So that was really pleasing to see. There are some risks and concerns around financial risks, slightly down at month 7 at 37 million versus 39. And, you know, we have received reports via Simon on SIPs and how we're working towards break even, but that continues to be a risk flag for us on the financial side, as does the overspend on prescribing, which has stayed consistent, currently at 2.1 million. So just, I would say those are the key sort of highlights from the finance and performance side that we're focusing on. Just on the commissioning side, I think we'll come into it on part 2, but we're obviously working through governance and accountability of any sort of joint commissioning group via the FPCC to the ICB, and particularly with respect to some of the Section 256 and Section 257 reporting. So I think we'll have a resolution there, but once that's settled, I hope what we will be able to provide as an FPCC is that regular reporting up to the ICB against the performance of those grants.
Very good. Any questions for Serge? Debbie?
So I'm aware that the local authorities now published its budget consultation, and I'm sort of linking this to the role of the FPC for monitoring the grants that you've just mentioned. Is there a role for impact assessments to be undertaken on any budget reductions or demand management schemes in that public budget consultation?
About us or the council, sorry.
Yeah, I'm talking about
the ICB.
The ICB looking at what's whether there's any impact on health
on us
commissioning from the public consultation on the council budget proposals.
I'm not sure we have been formally consulted, have we, as part of the council's budget proposals, but it doesn't stop us putting in our response as a consultee to the council's budget. Do you know, Ali, when the consultation period's over?
I think it's January, Kate, but I can double check. I sent Debbie the link last night to the public consultation documents. There are impact assessments already carried out as part of the requirement of any budget proposals, and they're in the form of our decision wheels in the documents. If any trouble accessing them, or if anybody wants to discuss anything, please let me know. But they are out there for consultation at the moment, and by all means, if the Finance Committee of the ICB wants to put a response in, that's great. Thanks.
So can I ask that QPOC puts the response in, and that Susan, you lead a piece of work around the quality, equity, impact that we think that potentially budget reductions might have on some of our more vulnerable populations, and that we could share that with finance and performance for a read across into likely impact on financial sustainability for the NHS.
And that needs to be done, though, the time the council's window of ending its consultation happens, so we can do that also formally. I think that's good practice that we write to them on that. Simon?
Sorry.
I was just going to add to following discussions last month. I just need to firm up on a meeting that we're putting in place with Tracy to run through the details of those plans. Yeah, Tracy Langley, who's responsible for the finance of the local authorities. So I expect that to happen before Christmas to inform the same discussion.
So can you make sure that happens when
Yes.
you're plugging in with Susan?
Yes.
Yeah, thank you. Ali?
Yeah, I was just going to reiterate that we have done equality impact assessment, so there is no need for an equality impact assessment. However, if you're looking at the budget proposals across the whole of the council and considering the impact on the NHS, then that's obviously a different thing and not the equality impact assessment.
I understand that.
I just clarify, did Ali say equality or quality?
Equality.
Equality, okay.
Yeah. Okay, thank you. So I think that was a worthwhile input. So, Martin.
Thanks, John. Yeah, no written report because we had our audit committee meeting only this week. usual suite of things that came to the committee in terms of internal audit, external audit, counter fraud, whistleblowing. I'll probably just raise two things of interest, which were external audit presented the final report of the CCG final year, so not the 3 months that overlapped, but the previous year. That doesn't need to come to this board again. We did the accounts earlier on, but it does need to be published, so that will be published through our website at some stage shortly. And the only other interesting thing, only because it's going to come up shortly, EPRR, Emergency Planning Resilience. Yep. We received some assurance that no doubt Karen will talk about in a minute in terms of the region and national review of our local arrangements. But we do consider that actually internally here, probably in the early part of next year, we may put our own internal audit to get some more assurance on how our EPRR is being set up, given the changes that happened with the advent of the ICB. And we did think maybe that would be one that we could do collectively, with the different organisations, given everyone has a sort of, I was going to say finger in the pie, but, an impact on part of our EPRR processes.
Okay, thank you very much. No questions, so I'm going to move on. So what I'm going to do, if I may, so Steve, I think it's probably worthwhile leaving as much time for your update as we can, if that's all right. So I'm going to start in a slightly different place. So Emma, would you be kind enough to give us your update first, please?
And I just wanted to highlight a number of exciting things that have happened in the last month. So colleagues will remember last time we talked about being in a preparation stage for the new community gateway, which is an 8 till 8, 7 day a week single point of access for colleagues in the health and care system. That went live on the 1st of November and has answered 715 calls in November. We're still collating, I think that might be higher, against a target of 350. 73 anticipatory care conversations and planning issues took place. And that's led on to a whole range of other support and for people in communities. I just want to thank colleagues in the voluntary sector. They've stood that up in 4 weeks. I hope colleagues in the wider sector are starting to feel the benefit of that, and we're getting a huge number of referrals from your organisation. So thank you for that. And linked to that, 2,800 attending the hubs, 26% of those for warmth bank elements. So again, that's been a really useful use of resource to support the community. I think we've got some challenges which I just wanted to bring to colleagues' attention, and I've already picked that up with Rachel around the ending of EU funding at the 31st of March. It's going to have a significant impact on some organisations within the sector, but I think we're going to have a bit of a financial summit to look at what's the widest possible conversation we can have around bringing resource into the sector, including colleagues like Crowdfunder and other places that we might be able to look to for support on that. And I just wanted to beg indulgence and finish on a couple of really nice things. So last night I had the privilege of being at the South West Personalised Care Awards. It's the first awards that we've had for personalised care across the region. And Cornwall brought home a number of awards. So we came back with highly commended in the pain cafe work that's being led by Dr Jim Huddy and colleagues in Imagine If in the sector. Cornwall Council and the Home Share Project brought home a highly commended award. And Volunteer Cornwall brought home the What Matters Award for their high intensity user service, which is commissioned by ICB colleagues. So I think we've got some congratulations. And if I could just finish on a person's story from the hubs, because I hope you'll hear this as an opportunity or an indication of what's happening. And I do think it's important that we hear people's stories in the board. So if I could just tell you a little bit about a gentleman in his 60s who turned up this week, so this came in on Tuesday, disorientated and with a bag full of medication, having been discharged from hospital following a fall. He'd been living on the streets for the last 2 weeks because he was homeless. Due to seizures, he'd lost his phone and had no other ID other than a letter from DWP. So the hub gave him a hot meal and a safe space to warm up for the afternoon, where he dozed on the sofa. They were then able to have further conversations with him and make referrals to the appropriate organisations. They got him an old phone that he could use to talk to housing colleagues and start to look at opportunities for housing himself longer term. He's been into the hubs a number of times since and is now able to stay with a friend. So, you know, we don't know what's going to happen to that gentleman going forward, but I just think it's a really lovely indication and a story about what the benefit that the hubs are bringing. So hopefully you're also feeling that within your organisations.
Very good. Thank you. Any questions or observations? No? Okay, so let's move on to Jane. Could you give us an update, please?
Thank you. I'll be very quick. So just two things really. I suppose one is, although we have got across Devon quite, we've done a lot of improved discharges, we still have a significant amount of challenges in relation to patients sitting within University Hospital Plymouth and discharges into Cornwall. Certainly something I need to pick up with the team outside of this meeting. Just in relation to UHP, because as I say, ambulance handovers continue to be a real challenge, although some small improvement, but not certainly to the level that we all require. There is now a sort of revised approach with a national team putting in support at a medical director, and also a nurse lead from outside of the patch, and also Simon Tapley, who's the Chief Officer for Strategy and Transformation, is also going to be based within the UHP and Plymouth and Western system for the next 3 months at least, whilst we have a focus on flow, hospital admission avoidance, as well as discharge support as well. So a real concentrated effort on that. So that was really the sort of the main thing. I mean, just in relation to the integrated care strategy, I will certainly share that when we've got our next iteration with colleagues in Cornwall. We've got a page turner, I think, next week. And of course, as we all know, this is a draft document, probably needs quite a lot of work still to get it a bit more succinct, but we'll be keen to sort of also look at the commonalities with colleagues in Cornwall. So that was it.
Thank you very much indeed. Yeah.
So I just want to pick up the issue of delays. So I've just pulled up on my phone the delays in UHP yesterday, and the vast majority of the delays are on the pathway 2 and 3. And one of the conversations Rachel and I have been having is how our Better Care Fund for the rest of this year, that's targeted at reducing hospital waits for people who are ready to go home, can target the pathway 2 and 3 patients out of acute hospitals, as well as the back end of reablement services for pathway 1. So we'll come back to that later on the agenda.
Okay, thank you. So let's move on to partner members. We'll start with Andy.
Thank you, Chair. Paper as read. I've got one other item to add, which came in after the deadline for papers, which is a good news story. Just to confirm, the Department of Health and Social Care has chosen Cornwall as a pilot for digital health checks. So these are health checks for people aged between 40 and 74 to screen them for markers of ill health that might lead towards cardiovascular disease. 3 of our practices have been chosen for an app-based response, and we've received some local and national media coverage positively, and I've received approaches from other parts of the country who really want to try and piggyback onto that.
Very good. Any questions? Okay, I can't see you, but Ali, are you on the call now?
I'm here. Yes, thank you. Happy to go next. Thanks, colleagues. I'll take the paper as well. I'll just pull a few points out for colleagues, though. We mentioned earlier around some of the outcome frameworks, and I just want to draw your attention to some of the performance data that's in my update, which is absolutely the adult social care outcome framework data, or key aspects of it anyway. We have continued to see some improvements around the numbers of people that are waiting for assessments and or services from the council. However, there is still much more to do here before we've fully recovered our position. And it's good to see that improvement continuing despite significant pressures across our system at the moment. And in relation to those outcome framework targets, we've actually sat down last week and we set 4 years targets for these areas of work. So quite ambitious on some of these aspects as well, and that's going through due governance in the local authority at the moment, and will be embedded in our outcome delivery plan around vibrant, safe, supportive communities. And once that's gone through due governance in the council, I shall bring that here and share that with colleagues at ICB. Just one other thing I just wanted to mention, and then one thing to ask of ICB. I just want to reference that we had a bit of a lock-in day, Joint Commissioners' Day, back on the 18th of November. And again, I just wanted to acknowledge the engagement and the open and transparent way that we worked together that day with Rachel O'Connor and her team, with the council colleagues, and there's an update in there around some of the work that we've already probably touched on today already. John, in my report, there were 2 asks from the ICB today. However, I absolutely that my second ask I will remove for this conversation, because I think we've touched on it elsewhere and we've had a conversation outside of this meeting, and we know how we're going to take that forward and look at that. So the ask here, I suppose, is that during the Transforming Care for Cornwall programme board a couple of weeks ago, there was a challenge around some of the use of the 256 monies for a head of intermediate care post funded. So really seeking clarity on that today from ICB, but happy to have that deferred to the conversation in part 2 later, if that's appropriate. Thanks.
So I'm not sure it's an ICB discussion as such. The issue with the PACE is it comes out of a programme budget. So I think perhaps we should talk about it in part 2.
Yep. Happy to pick it up in part 2. Was told it would come around here though, Kate, to ICB, which is why I've put it in. Thanks.
Fine. And what was the other? Just remind me, because I'm struggling to see it on
it was in relation to the ICPG, but we've discussed that yesterday, and obviously we've got...
and we'll definitely pick that up in part 2 as well. I thought that's what you were referring to.
Yeah, great.
Excellent. Thank you. Any questions for Al? No? Debbie?
So I'm going to again take the paper as read, and the ask really for this board today is to promote awareness of the 24/7 helpline for mental health. It's all age. You can see that it's well used. It was stood up very short notice during COVID. It's now being built in as part of our sustainable urgent and emergency care arrangements for those suffering a mental health crisis, and to also note the joint work that we're undertaking with the VCSE in terms of the wellbeing coaches and the impact that they actually have. So that's ensuring that we've got a more responsive response to those in crisis. So I'd like to commend that work, and just to note that the connection between NHS 111 and the mental health support line will be picked up as part of operational and business planning.
Just a very quick question. Is that a locally provided?
I can't hear you.
Sorry. Is that a locally provided support line or national?
It's locally.
Local.
Yeah.
Okay, any other questions? No? So, Steve, I know you've got quite a significant update, so don't feel under pressure to rush, but what would you like to add?
There's 4 things I'd like to cover, and to either add more detail or just provide an update to the report. So the first one's industrial action. So the report references some aspects of industrial action. Those things haven't changed. Particularly RCHT and CFT Royal College of Nursing staff voted and passed the threshold for industrial action, but neither of those 2 sites are intending to take industrial action on the 15th or the 20th of December. So that's in the report that maintains the position. There's a couple of other updates though. The first one is about South Western Ambulance Service. Unison have voted for industrial action in SWAST and passed the threshold, and Unison colleagues will be taking industrial action on the 21st of December. SWAST are still working through the mitigation actions, the derogations, and the contingencies around that. So at this stage, the providers are still working through that, and we can't provide a detailed update on the impact. Clearly, we're looking to minimise the impact on the delivery of urgent and emergency care services. In addition to Unison's action in SWAST on the 21st of December, GMB have also voted in favour and passed the threshold for industrial action. So GMB members of SWAST have indicated the intention to take industrial action on the 28th of December. So we've got 2 periods of SWAST industrial action, which may impact on services in Cornwall and the Isles of Scilly. And as we understand more details, I'd suggest that providers circulate that via Kate to colleagues within the ICB to update in respect of that. I'll cover just a couple of other things on industrial action, if it's okay. UHP, RCN staff voted in favour of industrial action at UHP. And again, UHP are working through the derogations and the impacts. That industrial action will have an impact on some outpatient services. And where there is an impact on outpatient services, patients will be contacted in advance of the industrial action. But it should not have an impact on urgent and emergency care services at UHP. We're also in a process of further ballots being undertaken. So the Royal College of Midwives and the Royal Society of Physiotherapy, we're expecting to get the results back over the next 2 weeks in respect to those ballots. And we understand that BMA will be balloting for industrial action in January next year. So as and when those ballot informations come back, we can update through the providers report to the Integrated Care Board, and clearly we can update in between boards via ICB colleagues if the situation changes or develops. And just to briefly comment on the Royal College of Nursing in the context of CFT and RCHT, whilst they're not taking action on the 15th or the 20th of December, that doesn't mean to say that there wouldn't be subsequent actions in next year as well.
Thank you. Just before you move on, in terms of UHP, maybe Jane wants to intervene here as well, but is there going to be action there?
There is, so RCN have voted in favour and are taking action at University Hospitals Plymouth.
Yeah.
The expected impact at this stage, John, is an impact on the delivery of some outpatient services.
Right.
So that could mean some outpatient services being rescheduled, appointments being rearranged. So those appointments may not take place on the 15th or the 20th. Colleagues at UHP are trying to mitigate and minimise that impact. So patients should assume their appointments go ahead unless they hear otherwise, and if there is an impact, patients will be notified around that.
And Jane, if I can just ask, in terms of the domino effect, may I ask what's happening with Royal Devon? Because if Royal Devon has a problem, do people get moved to Derriford, or is that not a relevant issue?
Well, I suppose that's what we're working through at the moment, certainly. But and I can get the latest in relation to the outpatient position circulated. I don't quite have it to my fingertips at the moment, but so I mean, my understanding is that yeah, we're looking at what mitigation we can do across the whole of Devon. But I'm certainly happy to get a more up to date briefing.
And Tim, do you want to add anything?
Not at this stage, John. As I say, we've got no further detail other than say we've got robust plans in place at the moment. We are now awaiting the national derogation framework.
Thank you. Back to you, Steve.
So that was the first item to update on. The second item is delayed discharges. So if I can just draw colleagues' attention to page 19 of 30, which sets out the position for RCHT, CFT and University Hospitals Plymouth. You'll see, and we've covered this before, there was some really good progress over October with an agreed trajectory to reduce the number of delayed discharges in our hospitals, and that progressed broadly to trajectory to the 31st of October. As you can see in the paper, that then deteriorated, particularly in RCHT, but also deteriorated in University Hospitals Plymouth over the following 3 weeks. That position's continued. So both RCHT and University Hospitals Plymouth have continued a deterioration in delayed discharges. And both acute hospitals are in a position with delayed discharges being about 45% higher yesterday than they were when we were on trajectory on the 31st of October. So as has already been commented, that is a significant challenge. It was identified as a significant risk in this paper, and of course it's been identified as a significant risk previously. Currently there's no indication that that deterioration will significantly change, and that's causing significant capacity challenges and constraints in UHP and in RCHT. So that's the first thing. The second thing to update on is the number of ambulance arrivals at Royal Cornwall hospitals. During the month of November, that increased by about 25%, increased from about 70 a day to about 90 a day. That brings us broadly back to pre-pandemic levels. So I think there was an expectation at a point in time that we'd see that increase in ambulance arrivals. and it's probably at least partly driven by the improvements in ambulance handover performance that have already been mentioned and recognised in the report, as ambulances are released more rapidly to respond to existing demand. But certainly that's placed additional pressure on RCHT. More generally across the SWAST footprint, the increases in November have been about 5%, so RCHT is a significant outlier with a 25% increase. Those two things together have had a significant impact on ambulance handover performance. So whilst Sanj and other colleagues have recognised the significantly improved performance that we saw for the previous 5 weeks, that deteriorated over the last 2 weeks. So the position for the week of the 21st of November at Royal Cornwall Hospitals was 574 hours, which was a deterioration but still within trajectory. However, we saw a significant deterioration the following week, the 28th of November, where that deteriorated to 1,151 hours. So a significant deterioration. From a UHP perspective, the ambulance performance has broadly remained static. Jane identified a slight improvement in the previous week, and that's correct, but broadly, University Hospital Plymouth's ambulance response time has maintained at that level. From an RCHT perspective, the performance last week has been maintained this week. So week to date, we're seeing the same levels of ambulance handover delays this week. However, the individual longest ambulance waiting time at RCHT is improved on previous months, with the individual longest waits being about 50% less than they were in September and early October. The key issue and the key risk, to be clear with ICB board members, is the one that's already identified in the board papers, which is the deterioration in externally delayed patients. We're currently significantly behind the agreed trajectory. The trajectory for this week was no more than 50, and we're at 119 yesterday from an RCHT perspective. And as I mentioned, from a UHP perspective, there's been a similar proportionate increase in those patients who are waiting to go home with some form of community care, or waiting to go to residential homes, nursing homes, dementia homes, or elsewhere.
Mary?
Yeah, sorry, just to go back to the balloting and the strikes. I hope I didn't miss it while you were talking, but do you have a picture on the community nursing teams? Because we've had one team has told us all of their band 5s are going to strike, and one community nurse team manager said they're going to treat them as snow days.
So we are waiting for some of the results from GMB and Unison in respect to mental health and some community health workers. So we don't have all of those results available to providers. So
it's going to be with the RCN strike, this particular conversation I've had.
Mary, perhaps raise that with me offline, because that's certainly not a position that I recognise in CFT.
Let's do that. Rachel, you want to ask a question?
It was more a comment when we're talking about the overall ambulance trajectory, Steve. So, and I come at this at a place in our absolute ambition is that those delays are as low as possible, not least for the individuals that want to go to the place they need to go to and be where they are, but also, as you say, the impact on category 2. But I think there's just a couple of things for us to recognise. When we signed off the trajectory, what we hadn't done was the assurance around the interventions that would actually bring back down in terms of that trajectory, and a key part of that is the work that we'll be doing around the BCF investment, because additional capacity to reduce that element that we currently have holding in that number is what will make that difference. I do think in some of those areas the evidence that we're seeing is we are keeping up with the weekly run rate in terms of some of the additions. I also think the work that we've commissioned through the SCC around the 4-week rolling average is really important, because we could take a date stamp of Wednesday last week, which was the lowest day that we had of overall delayed discharges, which was 217, which is the lowest that I've had since I've been here. And actually it was still a really difficult week. So it's clearly, and I know you're saying this, it's multifactorial in terms of the things that come through, as well as the work that we're doing internally through the flow programme. And I think that where that 4-week rolling average on a number of factors will help us get closer to close of all the things we need to do for our collective ambition to improve the holds.
And there's also, just to make that picture complete, I've read your IPR pack. Towards the end of the IPR, there's the trajectories for P0, 1, 2 and 3. based on the John Bolton work around, I think, is it, Susan, correct me, 90% of people over the age of 65 should be going home under their own steam. In that it shows that P0 is below trajectory, so that's people who just go home with nothing because they're ready to go. And Ps 1, 2 and 3 are above trajectory. And what that starts to describe is the picture that Ali would recognise around we send more people home with things. What we need to work out is that over-prescription, or is there something that's strange about the Cornish population in comparison to other elderly populations, because this is all over 65. There's no skewing by age on the percentages. So that said, it still means that we've got ambulances queuing. So whilst we're underneath the data trying to understand it, we need to do more to free up the front door of the hospital. And one of the things Steve and I discussed with Pauline Phillips and her team last week with Deb Lee from Gloucester is that looking at medical discharges before 12 noon is a really big indicator to help flow. And because surgical patients, our surgeons would like to send them home so they can list more people for surgery. On medical wards, the dynamic is different. So we need to get underneath and be really specific around who's waiting and how we emancipate that flow before 12 noon.
Can we come back on that? I've got a question I'd like to ask.
Well, just a couple of comments. Kate summarised quite right a huge amount of work which is underway and further opportunities to be progressed. Just to note Rachel's comment about the trajectories, aside from the trajectories, that there absolutely has been a significant deterioration in total numbers in P1, P2 and P3 patients waiting in Royal Cornwall hospitals and in University Hospitals Plymouth, and that's happening on a week-by-week basis. That is directly impacting on the ambulance handover performance, and I just think we need to be absolutely clear about that. From an optimistic perspective, we've got the allocation nationally of £7.1 million for adult social care directly to support discharge from hospitals, which is referenced in the board papers today, and that additional capacity potentially could and should directly contribute to this position.
Good. Okay, thank you. So my question is probably doesn't require an answer now, but when I look back even to my own chair's report, which probably hasn't been overly helpful to be accurate, but the first 7 weeks when we started at 1,146 and it's now 1,151, which is almost an identical number, we had 7 weeks of going southwards and getting better towards a number of just below 300, and yet in 2 weeks it's compounded twice. 300 to 600, 600 up to 1,200. Are we able to understand why? What are the drivers? Because it's such a material was going down slowly, and then with such a steep ramp upwards, there must be something that we could say that or those 2 or 3 factors have actually driven it. Have we got a clue as to what's driven the...
Absolutely.
Yeah, and the answer then is...
Well, in the report, we've seen the number of patients occupying hospital beds increase from 82 to 119. So that's a material impact from a Royal Cornwall Hospital perspective, and equally it's a material impact from a University Hospital Plymouth perspective. And if I give an example of what that means in reality, at Royal Cornwall Hospitals, the Tremenal unit was opened to provide 18 extra frailty beds. Those 18 beds are effectively full with a further 20 additional patients. And the impact that has, John, is there is then not capacity in the wards to pull patients from AMU to out of ED and out of ambulances. So the single material change has been a very, very significant 45% deterioration in the number of hospital beds occupied by patients who are medically fit and waiting for discharge because there is insufficient capacity in the community for those patients.
And just before I bring in Kate for the final comment on this, do we know when the 7.1 million will actually start to make an impact, and will it be spent on things that will actually start to help this side of Christmas?
So Rachel's going to present a paper later.
Yeah.
We need to do cause and effect spending, because I would like us to be really clear. If we don't think it's going to reduce hospital waiters, we don't spend the money, because it's not recurrent if we don't reduce hospital waiters. So we need to be really clear about that. In terms of the picture that Steve presents, because with anything that involves different agencies, then there are views around what's driving it, and absolutely, we have seen, so the numbers of waiters goes up and down, doesn't it? It was as low as 68 one day last week, and we're up to 115 as of yesterday, just in our CHT. The picture in Plymouth is largely improving. It's only 4 P1 waiters in Plymouth yesterday. The week where we had 256 hours lost was the week that the Tremenel unit opened in full. The SDEC frailty unit was open in full. We had no IPAC closures. I don't think we had COVID in the hospital. We are now going back to having closures of beds for IPAC, both in RCHT and CFT, and the additional capacity we've had has already reached its maximum capacity without any additional productivity or efficiency through increased flow through. That is exactly what we need to break through the BCF monies, to put RCHT in the best possible position to be able to serve our people this winter, and for us to be able to do the same with UHP. So how we get to the impact is different ways in because of different perspectives, but the impact for our citizens is the same. Okay. We need to free up the front door.
I think we've aired this openly. Yeah. Maybe we can pick it up again later on, but I think that was a good 25 minutes, which hopefully, Steve, you've got your...
I'm grateful for that, John. Thank you. Yes.
Okay, cool. Wow. For me, I love this little part of the session because you get a complete view from everybody when you add it all up. The whole is more than the sum of the parts. Okay, shall we move on? Lovely, thank you. So we have our EPRR paper. So that's Carolyn.
Thank you, Chair. So this is a really quick item. It's a requirement to bring the assurance ratings to the board. So this is our emergency preparedness, resilience and response assurance results. It's a must-do for all NHS organisations and organisations who deliver NHS services. All organisations complete a return, and effectively the ICB is modified by NHS England, and the ICB modify the partners' submissions, and then they're submitted. So this paper is really just to cover off the fact that NHS Cornwall and the Isles of Scilly ICB has been assessed by NHS England as being substantially compliant against the core standards for 2022. There were some good areas noted of best practice, and 2 of those they've asked that we're happy to share at a regional level, and that's around our Director on Call guides and also our EPRR work plans. Some other areas of good practice highlighted was our business continuity plans, our risk assessments and our collaborative working, which really did get some really good feedback, I have to say. Some of the areas for the ICB about further development have been increasing the number of trained logists. We recognise that that's something that we have to do across the ICB. At the moment there's 7, but we also need to think wider for how we use our logists and for incidents. So that's something we'll be speaking to colleagues about outside of here. The other thing that we've got to do is obviously look at further development and work on our system-wide instant communications plan for the ICB, and system-wide media training. So that's something that's come up in a couple of meetings for various things. So it's not something that we wouldn't be surprised by. As far as the provider assurance ratings have been concerned, there's been really good evidence to support the compliance for our colleagues. So RCHT, substantial compliance, CFT, substantial compliance, Kerno Health CIC, full compliance. And I have to say that Kerno Health CIC have done remarkably well over the last 2 to 3 years with their EPRR assurance ratings, and they are looked at as quite an exemplar. Totally PLC, for those who don't know who Totally PLC are, they were the parent company for Vocare for the 111 call handling for our integrated urgent care service. They are no longer that provider, but this is for the year 21 to 22. ESEC, our patient transport provider, substantial compliance. They were assessed by East Anglian ICBs because that's where their parent company is. And South West Ambulance Service, full compliance, but again they're assessed by Dorset ICB. So really this was just to highlight to the board that this has taken place, Those are the compliance ratings, and it's really just for acknowledgement from the board.
Just before we move on for questions, Martin, anything you'd like to add?
As I said, we received the same report. It's good to see the assurance that's been provided externally, obviously mainly by the region for us, but as I said, we did think that in the next financial year sometime we'll have our own internal auditors have another look.
Thank you. Happy if I move to the recommendations? Yeah, okay. So to note, to endorse, to receive the verbal update. I think we've done all of that. Are you happy to accept those recommendations? Yep. Done. Thank you very much, Carolyn. So now we've got the integrated performance report. I think, Kate, you and I talked about you leading off on this.
Yeah.
And I'd like to leave enough time, if I may, to come back to Margaret's question before we end. So if you'd like to kick off on this, please.
So I'm just going to do a high-level canter through, and then if people want to speak to Simon, Rachel and Susan on the specific aspects of it. Over time, we will include workforce in here so that it's a complete triangulation of the money we spend, the activity by, the quality of it and the people who provide it. So we have rehearsed today how we're doing with time to treatment for elective care and also for emergency care. And we know that for both of those things for our county, we have plans, but those plans are in part difficult to deliver because of delays across our system. We know that our ambulance holds, so improvement is rarely linear for these sorts of things. We've seen some good weeks and we're starting to see some, what's the word I'm looking for? Oh no, when things get worse, challenging, thank you. Challenging weeks, but we remain committed as partners to do what we can to do the right thing for our people, which is getting into hospital when they need to. We've seen an impact on flow, and we know that an impact on flow starts to affect our excess mortality. So our HSMR last month was 1.35, which says that 35% more people die because of we are thinking fractured neck of femur, time to treatment for heart attacks and time to treatment for strokes. That had started to improve, so that absolute link between delayed access to treatment and excess mortality is made in the figures we see in front of us. We've had a discussion with our informal Health and Adult Social Care Oversight and Scrutiny Committee yesterday on MIs, so heart attacks, stroke and also our cardiology services. And we are clear that we're challenged, but we've got plans in place to be able to meet those challenges. One of the things that is in the report that you might miss is around our antimicrobial stewardship, which is led on behalf of us by Dr. Alistair Grant from our CHT. So our levels of C. diff are rising, and with levels of C. diff rising, that starts to, should be starting to alert us to the fact that we might have more sepsis around our county. We know we're going to be using more antibiotics because of the strep A presentations we've got at the moment. So I would suggest that we ask Alistair to come and talk to us as a board around antimicrobial stewardship, antibiotic availability and our plans going into the winter. And I'd just like to finish around our safeguarding arrangements. We had a review from NHSINE yesterday, and it wasn't just the ICB of these people around the table. Fiona Fields was there with Simon Mould, and I think it was really good to hear that we have landed our safeguarding arrangements really well under the amazing leadership of Charlotte Baker. Charlotte's got two names. That we've landed it well, and that Fiona Field was wanting to say to NHSINE that she feels very comfortable with our safeguarding arrangements, and next month we'll bring the annual state adult safeguarding annual report to the board for a focused discussion.
Thank you. Okay.
Could I just add to that? Because next month we are due to have a quality deep dive as part of our forward plan. So what I'd like to propose is that we bring not only Fiona's paper, but the review that NHS England have done, and we have a focus on safeguarding, Chair, if that's okay.
I just think when I did my aspiring chief exec mock interview, I managed to do all of it without mentioning money, and I've managed to do it again.
Oh, well, there you go.
So Simon has in part updated us around where we are with the money.
Very good.
So if there are any questions, then address them to Simon.
Okay, I'm going to kick off on. Okay, is this a new format? Okay, that you want
it is. It's a new format. So we thought if we bring it together, so we triangulate it and then have specific areas of focused discussion.
So if I can just pass an observation on this and then get other people's thoughts. I really welcome this because it's something about bringing together our top priorities, which is almost part of the Transforming Care for Cornwall updates we were looking for. Just intrigued as to why you've got on page 4, you've merged dementia into this, why you wouldn't separate out and have the 5 system priorities so we can have clarity. I'm not clever enough to work out which bit is in which priority, that's all.
So we said that dementia would be a separate priority for a year, so I think we're sort of a little bit ahead of us ourselves. We can take it out again.
Yeah, so we've got 5 priorities plus 3. I think we need to have, if that's all right with you. But I think this really works. I mean, for me, it's clear. I mean, what do you feel? You happy with it as a paper? And what about the substance of the paper then? Let's get into that. Any challenges, any questions, any concerns particularly you want to tease out? Yes, Debbie.
I think it's really helpful to see it at a system perspective because it does enable triangulation. So I was particularly interested in, Kate, you drew our attention to it towards the end of the paper about the P0, P1, P2 and 3 against the John Bolton trajectory. But I was just playing that back in my head against what I read in the local authority partner update provided by Ali that suggests that we're seeing a reduction in the number of admissions to long-term care, and that's below the England average and now the South West average. So I'm trying to compute the two.
So I asked that question at the Informal Health and Adult Social Care Overview and Scrutiny Committee yesterday, and Ali, the woman whose name I can't remember that was there for you, Emma did say, well, you could interpret it in that way, and I said that's how I've interpreted it. So if there is a different interpretation, then Debbie and I have both seen it in the same way, so it would be good to know what it is.
So first of all, low is good. And the performance report is 12 months rolling data. So where you see it reduce, it could be that this time last year we were more reliant on placements. I think it's also particularly skewed when we hear from Steve on the number of people that are potentially waiting on the P3 pathway. So there's a lot of things that come into play there that we need to understand better as a system. But actually low is good here. But we do have an anomaly where people are going for a P3 pathway out of hospital. They won't be counted against that indicator until they're in long-term bed, so it doesn't pick up those people while they're in that assessment period as well. So there's all sorts of things in the mix there, Kate. They're not necessarily like for like.
I think it would be really good to do a focused piece of work because I read it in exactly the same way as Debbie, that because it was a continual below South West and national average for bedded care in comparison to everybody else. So I think it would be good if we could bring the John Bolton figures with our utilisation of residential and nursing home care with our waiters, and then it gives us a good triangulation around that interface with intermediate care and long-term care.
Yeah,
I'd really welcome that because Kate. Low doesn't feel good when you're in UHP, where I think it takes 5 times as long to get into a care home. If you're in RCHT or CFT, low doesn't feel good. So I'd really welcome that.
We're talking about slightly different things, Debbie, and I welcome the piece of work as well, because I think we need to be clear this is about long-term admissions, not those people that are going into beds to be assessed. We've got lots of things that have happened over the last couple of years in the Cornwall market, would be my observation, that will skew that figure as well. So we need to understand that, and I think it'd be really helpful.
Okay. Sanj?
Just, I think the format is really helpful. I think in some cases it's good to have the denominator in terms of the stat, but also as a percentage of what, and also the sort of target we're getting to. Not in all cases, just 1 or 2, and I'm happy to provide feedback afterwards. On safeguarding specifically, I mean, it's encouraging to hear we're getting positive reviews on that, and good, I think, Susan, that we're going to have a deep dive, because just looking at the metrics, it doesn't give me at least the full story, you know. So calls to the Safeguarding Children Multi-Agency Referral Unit, great, but how many are resolved? How long does it take? How many are outstanding? What's the average we're trying to achieve in terms of resolving a typical call? That sort of information would be helpful as well.
So Fiona's feedback to us is that we are much less passive than we used to be around the management of safeguarding concerns. So I think those internal standards, just as we would have for paying invoices, what's our internal standards for the resolution of safeguarding? And in particular, we know that we've got high levels of domestic homicide reviews ongoing. where's our ambition and what are our plans to make sure that the domestic homicide doesn't take place in the first place. So that is we will come back with that, Sanj.
So Sanj, as always, you and I are on the same page here. I'd actually written down something you just said, but I just want to take it one stage further. In fact, I'd like to challenge all the committee chairs to ask the kind of question you're asking, because this is a fantastic format, and we're on a journey. Okay?
Yeah, absolutely.
Completely on a journey. But when we've got statements like the average length of stay is X, which is great, it doesn't tell us where we're going, by when, to what degree. Some of the things make statements like improved ambulance handovers, from what to what, by when. So there's something for me about how do we choose to get your perspective as an executive group on the things you want to do, we sign up to, and then we scrutinise them in committees. Because if not, you can't scrutinise them.
Yeah.
So I would ask each of the committee chairs to think about how you work with your executives.
Although ambulance handover is the one thing where I can see the trajectory.
I was using it as a bad example. I used it as a bad example. But just trying to make the point about, because I'm increasingly challenging you about how are you scrutinising the executive group to make sure we achieve the things we say we're going to do. We need to make sure that you have got metrics that you're happy to be scrutinised against in that.
And Susan's just whispering about SPC charts, because when we look at the 256 up to 115, what was the special cause variation that caused that to happen? Because then we're starting to get into some of the weeds that are important at times around our global position. So we will take that away and we'll start looking at how we can use more SPC charts, which then will have trajectories that will give us rolling averages, and we'll understand why things change.
Okay, so when I move on to the recommendations, this particular time, I must have missed this. It's quite a wordy set of recommendations. Okay. So what is it that you want out of this? Really?
So if I'm making them up as I go along now.
Well, no, if you look at those, I'm not quite sure what you want out of it.
So I think we should note the performance issues. This isn't the only place we see performance that comes through, but this is the triangulation. This is the only part of our meeting when we see what our money buys, what the impact of it is, and what the quality metrics are. So I'd like to know that people are happy with this as a way of presenting this information. I think we should note that the committee have the board have just made an ask for better ways of tracking performance over time and denominators against which we measure performance. Note the ongoing development of the integrated performance report, and I'd also like you to note that workforce will form part of it for the future. Please don't ask me to say that again.
No. Thank you for doing both chair and chief executive role there. So just very grateful. Okay. You happy with those recommendations there?
Yeah.
Steve?
Very happy with those. I just appreciate, clarity on the conversation that we were having around is it good to be below the southwest average on admissions to long-term care versus we've got 140 people waiting for long-term care. So if there was an action, it'd be helpful just for all of us to be clear.
We'll take the floor. Okay, colleagues, let's move on from...
Sorry, the money. I know Kate almost wanted to get a gold star for not going through the money, but I would like to just highlight that as a system we're carrying significant risks, particularly in our CFT around agency. And whilst we have got an agency controls programme, nevertheless, going into winter, we're carrying additional costs because we're already in escalation and surge, and that is requiring more agency costs at premium rates.
Noting that for now, we have a section on the part 2 for the whole finances. Let's pick it up then, if that's all right.
I also suggest there should be 2 pieces of focused work. Yeah. One is around the debate we had around hospital waiters and usage of long-term care. The second bit, I think, if we take into part 2, is the whole workforce piece around agency, retention, surge. I think that's a piece of work all of its own.
Okay, thank you. So, left 5 minutes because Margaret asked the question at the very start about refugees and what we were doing about that. So I think we've captured the question. How were we able to Susan, how were we able to respond to that, please?
So in terms of the question of the refugees, so currently we have 126 gentlemen that are in the New Quay Beresford Hotel at this moment in time. We get 24 hours notice, Margaret, if we're going to get any more folk silent. So we've not, and I think we need to be careful about some of that information, because I was told initially there were 6 it's gone to 2, it's gone to 1. So I think we need to be really careful about some of the messages that come out around people seeking asylum, because I know that some of the press around these people have not been helpful or in any way compassionate either. So we have set up a cell under the System Coordination Centre that is supporting the Beresford and supporting primary care, particularly the Narrowcliffe surgery, who've been under a fair bit of strain looking after these individuals. So we've we've done our health needs assessments, and thank you to system partners who've supported those health checks. In fact, our vaccination team is going in today to offer vaccinations for COVID to those individuals. We've been able to supply changes of clothes, because some of them have arrived in the country with no decent footwear, no coats. So we've been able to do that. We've got translators in place, because the asylum seekers in the Beresford, they come from 10 different countries across the world, so getting translators in has been no mean feat. And I've put my deputy heading up this cell, and she's gone in and has done some regular visits into the Beresford, as have our local authority colleagues, and also working with people like Rachel and, oh my gosh, her name has just gone completely, Ruth. So we're keeping we're keeping close support, Margaret, to these people, because they've had emerging health needs, which I'd rather not go into in this forum, if that's okay.
Also, I'm worried about oncoming mental health requirements.
And we're putting support into the Beresford around mental health. Big issue.
Would it be an idea if you caught up afterwards as well?
More than happy to do so.
Does that work for you, Margaret? No, you've raised a great question.
I know it's been mentioned and we're in part 1. Can I offer a suggestion that it is a risk to maybe name the location, given that we've had, in other parts of the country,
Unfortunately, Sanjay, it's been in the press. We've tried to embargo as much of the information as possible, but we've had quite a few stories, which is why I'm asking to be cautious about any other information that's coming out about these people.
So can we call out what we potentially have seen? So we have seen hysteria around the health and care needs of people who have left their country of birth or origin, terrified for their health and safety, and they've come to stay with us in the UK, and we almost do that again. We've been xenophobic and racist in the reporting of this. So as an ICB, I'd like us to say, that no haters, that our intolerance for that sort of behaviour, and our determination to make sure that we look after our most vulnerable in the best possible way. And partners around this table have been really fantastic, from digital hubs to health checks to clothes to everything. So we just need to continue to do that.
Okay. Thank you very much. Thank you for raising that question. So let's move on to item 17, which is the forward plan. So just so I can be really clear who's coming back, we've got 2 main strategy papers coming back. So Rachel, you're coming back. Is that right? Rachel, you're coming back?
Yes, I'm coming back. Yeah, she will come back again. She will.
No, I'm getting old and I stuttered, didn't I? You're coming back on the dementia paper?
Yes, that's correct, yes.
So you're leading on that?
I've recently had a baton handover from Steve as SRO for dementia.
Okay, fine. And you're happy with that? Lovely, thank you. So Rachel's coming back. The SRO for mental health, LD and autism is actually Adrian. So is it Adrian who will be coming back to us? You're happy with that? Fine. So we'll be inviting him to come. Yep. Excellent. And in terms of the other items on there, I'm not going to go through them. Kate, you've seen them, so I'm assuming you're happy with them. Is there anything else people think should or shouldn't be on these items for January? Because this is then the list of things which the team will go away and focus on.
Can we do an I'm sorry,
Carolyn.
John, can I? Sorry.
Sorry, I'll come back to you in 1 second. Carolyn?
I just make a point that we will just change that the finding integrated care strategy will have Rachel's initials against it rather than mine. Okay, thank you.
Yes, bear with me, Trudy. It was Ali next.
Thank you. Just a really quick query, not about January, John, but February, if I may. There's children's services, and I'm wondering if that's my initials next to it.
Probably.
And if so, what is that you're requiring? so I can be really clear about what work needs to happen, and whether it's paediatric services in the NHS that you're looking for, or whether you're asking Mary as a partner for some information.
From memory, I think this was one that was more aimed at Meredith, actually, coming back. I seem to recall, maybe it was a discussion I had with Barbara Ellenbrook.
In the partnership space around children's services, I'm not really clear why children's services are
We'll do is we'll take that one
reporting
offline, and
Okay,
Kate, if you
brilliant.
can, you can work. So we're not committing to that one, but Kate, you take that offline and come back with that. Trudy?
Yes, we will actually have to bring a joint forward plan back every month, probably January, February, March, just so you've got an update, because there'll be lots of speed going on. So it was just to recognise that.
So the only other thing to tease out here, I mean, it is in here. There is the draft 5-year forward plan in February, but I would encourage you, Kate, to be really explicit in terms of the journey for budget planning that goes through.
Absolutely.
Cool. Tom?
We've got workforce in January as well. That's not on the forward plan.
That's in part 2.
Oh, sorry, beg your pardon.
That's okay.
Just Simon's not in the room, I'll take away the action around we'll bring a paper to the January board that has all of this sign-off, the pipeline for sign-off and for consultation on our financial plan.
So just being, again, sensitive to dates, I think you'll find that even if we look at the March budget plan, Kate, if it's the 12th of March, it's almost at the end of March, sorry, the first week of March, you need to have the papers out. You just need to be really clear. Are you able in January and February to be in a place where you can have board papers for budgets ready for the 12th of March? That's the kind of planning.
Yeah, we're going to have to, because they'll need to go through statutory boards on their way through to here.
Yeah, and that's why I don't think we've got to the end of March. I think you've actually got probably to the end of February.
John, can I just clarify? Because I think we're bringing the overall system workforce strategy to January and then a separate part to part 2.
I was expecting a part 1 update on workforce strategy for January.
In which case, this is why we're having this exact debate now. So the only challenge I'm going to give, particularly yourself, Kate, is that can we make sure we have enough time to be able to have a quality conversation? There might be some papers that need to be pushed together. Just think about how today's gone. I'm sensitive that we spend maybe no more than 10-15 minutes on quite key topics.
So we've got Fiona Field coming in January, and it's a statutory piece that we receive the adult safeguarding report, and I think that will need half an hour. So Trudy, you and I need to sit down and go through a plan.
Potentially John Clements as well doing the children's safeguarding report, but I'm still waiting to hear back from him. So that that's
what I mean. It's not just the list of here; it's how we manage quality time on these sorts of, particularly if you've actually got 2 major strategy documents coming there as well. January feels like a huge set of topics if we now add workforce to it as well. So I think this has been a helpful.
Do you want us to move to February?
No, I think I'm saying to Kate and to the board,
have a look.
Just plot out January, February, March, such that you cover it all off to your collective satisfaction that we hit all the deadlines and dates that we need to achieve.
I'm just also mindful of the rhythm for receipt of papers, because effectively you'd be looking for quite comprehensive papers by the 5th of January, and given the likely operational pressures and the Christmas and New Year period, I'm wondering whether, if something's not already been written, whether it ought to be slightly later in the cycle.
And do you know what? That's absolutely the reason why we go through this, because in reality, are you going to get that number of papers written by the 5th of January?
So we've got an executive on Monday morning, so we'll discuss it on Monday. And then if we contact committee chairs to make sure committee chairs are happy and send out a revised forward plan for board.
Yeah. SEG dependency is the 23rd is the next meeting, I think, of SEG, if there's things that need to go en route to the 5th.
So I think what we're empowering you, Kate, as a group, if that's all right, is to look back from the 1st of April, look at the board dates and when the board papers go out, look at that list of and some of this is meant to be a rolling 6-month programme, so maybe you just push what you can back out over 6 months, but some of those things that are 1st of April dependent shouldn't be squeezed out by things that possibly could wait until April, May. I know you know that, but you just need the mandate from this group. Are we happy to give that mandate to Kate? Yeah. Does that work for you, Debbie?
Can I?
Yes, Ali.
Sorry, just really quickly, because I'm really mindful that we talk about joint integrated workforce strategies, and I'm just wondering where the partnership governance is and whether some of this should be going to ICP before it comes to the sovereign organisations, because I'm not sure what flight path that's on in the council, if that's a joint integrated with the council workforce strategy. And I just wanted to make that point around the governance, if I can. Thanks.
Yeah.
So I think at this point, Ali, we haven't got those joint plans, have we, between the ICB and the ICP? So I think we're going to have to assume for this this year that we will still be planning in isolation but linked, and then next year it'll be integrated. Otherwise, we won't hit all the governance timelines that we need to.
Yeah, recognising like a lot of these things are going to be drafted in their early days anyway.
Yeah.
Okay. So there are no questions. Moving on then. Happy with that? No questions from the public? Trudy?
They were no questions in advance from the public,
Yes.
John. I don't know whether there's anybody on the call that is
Okay,
from the public
good
that would like
challenge.
to make.
Anybody on the call that would like to ask anything from the public? No. So just before we close then, I think for good form, we ought to just again recognise and thank Helen for everything that you've done with us in this short period of time. We wish you all the very best for you and your family for the future, and thank you for everything you've done for us. So thank you. Thank you. So close the meeting. How about that? Just coming up to 1:45. I think we have half an hour, and we're going again at 2:15. See you at 2:15. Thank you very much.
Thank you.